Hi, everyone. My name is Karen Flanders, and I am a metabolic and bariatric surgery nurse practitioner and coordinator at Mass General's Weight Center in Boston, Massachusetts. I welcome you to this first Integrated Health Obesity Summit. I do not have any disclosures or conflict of interest to report. Before I share the agenda, I want to first share a little background about the Obesity Summit. For anyone not familiar, the Obesity Summit was a concept developed by Dr. John Morton and included an in-person meeting of the minds of many organizations that have been impacted and or affected by obesity and treatment of obesity. Unfortunately, when the pandemic hit, it put a halt to the summit. But our integrated health membership would like to revive the summit. The summit presents a unique and valuable opportunity for thought leaders in integrated health across various disciplines and organizations to unite. The goal is to foster the exchange of ideas and the development of action plans aimed at delivering optimal, coordinated, and effective care to patients with obesity. Today's focus will be on the 2022 American Society for Metabolic and Bariatric Surgery and the International Federation for the Surgery of Obesity and Metabolic Disorders indications for metabolic and bariatric surgery. Today's agenda includes the various updates and recommendations to the indications for metabolic and bariatric surgery. I want to thank the speakers who have agreed to be here today, most of whom are members of the ASMBS Integrated Health Executive Council. I also want to thank keynote speaker Dr. Shanu Kothari and our closing speaker Joe Nadglowski for taking the time out of their schedules to make this summit a reality. And I want to thank all of you who have taken the time to be here today to be a part of this revival of the summit. So sit back and enjoy the show. Let's get this show started by introducing our keynote speaker, Dr. Shanu Kothari, who is a metabolic and bariatric surgeon and chief of surgery at Prisma Health. He is also a recent past president of ASMBS. Sit back and enjoy his presentation.
Hello, my name is Shanu Kothari, and I have the privilege of being the Senior Past President of the American Society for Metabolic and Bariatric Surgery. I'm so excited to be able to give this keynote address, and I want to thank Karen Flanders for the opportunity to present this important talk to you. These are my disclosures, none of which would really have anything to do with this specific talk. However, my other disclosures is that I have been the past chair of the Clinical Issues Committee. I've attended the Obesity Summit when it was in person on several occasions and met a lot of individuals from other societies. And in doing so, we wrote several collaborative papers together, some of which are listed here on this slide. And I look forward to other collaborative efforts that will come out of this summit as well. Nobody knows the multifactorial impact that obesity has more than this group listening here today. We know that it is complex, there's multiple aspects to it, and that's why we do take a multidisciplinary approach to the care of the patients suffering from the disease of obesity. Sadly, it is from a social burden standpoint behind only smoking and war in terms of social burden. We're actually making strides in terms of illiteracy, clean water, and child undernutrition, but obesity continues to climb and being a challenging problem from a social standpoint around the world. We can see that as demonstrated here on this heat map on the number of population with BMIs greater than 30 by country. This, as we know, translates also into a significant burden in terms of mortality related directly to obesity and its comorbid conditions, with preponderance in the Middle Eastern countries. And with few exceptions, as the economic prosperity of the country goes up, so does the problem with the disease of obesity. However, when you look at our 60 plus years of information around metabolic and bariatric surgery, the penetrance of that which we offer to our patients is still vastly underutilized. You can see as represented here in these various countries, and you can see where the US specifically sits in relation to that so-called 1% of eligible patients that we talk about getting access to our life-saving and life-changing care. All the while our insurance companies continue to make record profits, particularly emerging from COVID, we saw as many patients were not getting health care and utilizing those resources, those premium dollars stayed with the various health plans as they continued to profit. While many of the health systems, my own included, suffered significantly to the point where most of us were losing money as we emerged from COVID. This is an important slide that I share within my organization, and it's important for all of you to know this slide as well, which we all talk about the health systems and the cost of health care. But when you look at the health plans that own many of those health systems, look at the disparity in the size of the bubbles of the billions of dollars that are coming in premium dollars to the health plans, but are not going out even to their own health systems that they own. So those premium dollars that our patients are paying are there. They're just not being paid out for the services rendered. In our case, metabolic and bariatric surgery and comprehensive care of obesity management. The analogy I tell every one of my patients is, think about if you went to a restaurant and you ordered a meal, but the meal never came, but you got a bill. Now, would you pay that bill and leave? No, you'd say, I want to talk to the manager. And you would either not pay the bill or you would get your meal before you paid this bill. But this happens in healthcare every single day, and it doesn't matter what specialty you're in or what country you're in or what model of healthcare system you're in. But this happens every single day where our patients are paying into their healthcare system but not getting the services rendered back to them. And why is that? Because the health plans are holding on to those premium dollars and not paying out for these services rendered. Now, not all of our patients that seek metabolic bariatric surgery actually are candidates or go through with it. This is a paper I wrote many years ago looking at why some of our patients didn't ever make it from seminar to surgery. And if you look at the breakdown of the patients, there's a handful that it was just personal choice. After they were informed, they thought maybe this isn't one for them. There was a slice that we thought were either medically or surgically unfit and not safe enough to undergo the surgery at that time. But if you look at the biggest slice of the pie, it's in the upper right. It's insurance denials and unattainable insurance prerequisites. What's an example of an unattainable insurance prerequisite? It's literally a plan that I know of that said, yes, we'll cover bariatric surgery, but you need to wait documented in your doctor's office, your primary care doctor's office, once a week for 3 years. That is a de facto denial. There's no way realistically. So when you put all that together, you see the biggest slice of that pie is insurance denials and unattainable insurance prerequisites. So not only did we present this data at the integrated health section of ASMBS the year that we analyzed this data, but 3 years later, I took that slice of the pie, that cohort of patients who were deemed candidates by our multidisciplinary team and never had surgery, and I followed them out for 3 years, and we tracked them within our health system, and we said, what happened to them? Well, guess what? The black bars are all of the new onset diabetes, sleep apnea, hypertension, reflux disease, and hyperlipidemia that was identified just in that cohort of patients over 3 years. Now, think about it. This data is 15 years old. What has happened to those patients? How sick are they now? How many of them have tragically no longer with us and have succumbed to obesity-related comorbid conditions because they weren't offered this life-changing, life-saving surgeries that we offer? So flashback to 1991. Other than the fact that I was now a first-year medical student, when you look at the average cost of a new house, what a gallon of gas was going for, and my gosh, when you look at what eggs go for now versus the 85 cents that they were going for in 1991. But what else happened in 1991? Well, it's hard to believe, but Silence of the Lambs was the #1 movie of its time. The Firm was the #1 book that went on to become a blockbuster movie as well. And of course, Cheers was the #1 show. Full disclosure, the only day I did not, I couldn't study in medical school. I was so distraught was after the final airing of the final seasonal episode of Cheers, but I digress. But this was going on in 1991. What else was going on in 1991 was the NIH Consensus Conference held a panel. Now, of these panelists, they had 14 stakeholders on the panel. Only one was a surgeon, and he was a retired general surgeon at that. Now, the speakers was the who's who of the ASMBS, of course, but there was only one surgeon and no bariatric surgeons on this panel. Now, think about it, where we were. This is data collected from the 80s on expert opinion and consensus. So a lot of procedures had not been created yet, so to speak. There was certainly no minimally invasive techniques, and there was no prospective randomized trials at the time. And what did they come up with at this guideline? That which we all know, the original 1991 consensus. BMIs greater than 40 are patients who are candidates, or 35 to 40 with significant comorbid conditions and documented dietary attempts that were ineffective. Now, when you think back to 1991, let's, for example, look at the American Heart Association's and the American College of Cardiology's guidelines in 1991 for ambulatory cardiac catheterization. If you look at the fine print here, well, guess what? Hardly any patient that nowadays gets an ambulatory cardiac cath would still qualify, because they've made significant strides in the last 30 years, and their guidelines have been significantly updated. Look at the patients who would not be allowed to have a cardiac cath in an ambulatory setting. Patients with insulin-dependent diabetes, age over 75, severe obesity. Think about this. We have matured in our understanding, our techniques, our data, and now we have mature data for our cardiology guidelines. Nobody else is trapped with 30-year-old guidelines. The stroke guidelines are not 30 years old that we still abide by and health plans abide by. Our cardiology guidelines don't, but metabolic bariatric surgery is still trapped in the past. So this data has been weaponized against us now. And we know now that a lot of this stuff that was expert opinion and consensus has been translated now into non-evidence-based barriers for our patients. So they've taken that line about ineffective weight loss, and many health plans have created their own burdens and hurdles that patients must overcome with no data to support it whatsoever. The ASMBS has been very proactive in this arena as well, and has taken out position statements showing no level 1 data to support this. What have I always said in all of my talks? It's multidisciplinary team recommendations for weight loss that are important, not insurance mandated ones where they don't know the patient. They're sitting hundreds of miles away and just trying to create barriers to access to care. We know what's right for our patients, and we know which patients would probably benefit from some weight loss working with our team prior to surgery versus those who don't, not the insurance company. So then what happened after that? In 2004, Dr. Henry Buchwald, one of our icons within metabolic and bariatric surgery, he too wanted to see an update to the 1991 NIH Consensus Conference statement. Because what had happened now since then, of course, now we're in our infancy, but we were emerging. Many of us, myself included, we're now fellowship trained in minimally invasive surgery, and we're a couple of years into our practice, and we're seeing growing practices, but also, and the benefits of minimally invasive surgery, but also seeing massive barriers with regards to access to care from insurance carriers not covering the surgery. And so he saw a need to update these. And interestingly, this is an important slide that most people don't even know, that the NIH themselves, on their own website, with regards to the 1991 guidelines, after they were 5 years old, said it's solely for historical purposes, and this data is likely to be out of date and at worst simply wrong. Wow. But most people don't know that, and certainly no health plans know, because they took that data, they weaponized it, and they made it policy, and it's been in place for 30 years. So Dr. Buchwald convened a group of individuals. The sponsors were, as it was called, the ASBS back then, and its foundation. And guess what? They invited the NIH to hold the conference. They refused. They invited NIH to participate in the conference. They refused. And then when it was done, they invited them to acknowledge and support the conference outcomes, and they refused that as well. Now, another icon, Walter Porres, was the chief moderator and organizer of the event. The Honorable Tommy Thompson, former governor of Wisconsin, who I've heard speak in the past as well as coming from Wisconsin, and the Secretary of Health and Human Services at the time gave the keynote address. And then it was the who's who of speakers from ASMBS at the time who again spoke at this session. And these were the recommendations that they made. They tweaked what they thought were the NIH, they were seeing emerging data specifically around this BMI 30 to 35 with a comorbid condition. So they saw this as an update of the 1991 NIH statement that was ultimately put forth. Now, what was the implication and ramifications of this, of the who's who of our field getting together to put this consensus conference panel together? Essentially, none. The NIH did not endorse it. Key societies did not endorse it. You could even argue that the ASMBS technically maybe didn't even endorse it and continued to publish and reference the NIH 1991 recommendations. So there was no impetus for the NIH to continue to put new guidelines forward, and it's been rarely quoted since. So fast forward to 2013. Now the NIH has been deliberating about all this data and decided to have a review panel of folks who were experts in obesity. Now it had 23 panelists. This time there was only one surgeon, our very own Bruce Wolf, an amazing surgeon gifted in evidence-based reviews who was part of the panel, but the only surgeon. And tragically, again, the ultimate outcome of this was referencing other society guidelines, no referral to the American College of Surgeons or the ASMBS, and no official statement about medical or surgical guidelines. And the death nail, they continue to reference the old NIH 1991 guidelines. And if you look at bullet point number 2, this was the death nail. It was insufficient to either endorse or encourage surgical intervention for the patient less than BMI of 35. So this really set us back. And then what else happened? Thank you, NIH, in 2013. But guess what? They got out of the business. So they stopped doing consensus conference statements after 2013. So we are been trapped in the past. So here we are. There was a call from, if you can see, from Dr. Buchwald reflecting back on time now about what really needs to be done. We need more society guidelines. We need updated contemporary guidelines. And the 2004 panel's been unrecognized, unremembered, and ignored. And so a desperate need to, continue to update this. But this 2004 guideline never got traction. So this was our burning platform. And at this point, then, I became president of ASMBS. And one of the great principles of in a book called Visioneering is you must problem cast before you vision cast. And we had a problem. We had a society doing great work, now larger body of evidence, multi-center trials, prospective randomized trials, level 1 data. And we're still trapped with this weaponized constraints on us by our health plans about 30-year-old data. And so this was one of my main initiatives when I was privileged of being president of ASMBS, was to convene at our executive council retreat held in Charleston, South Carolina. And this amazing group of individuals that were on the board at the time, I commissioned them and said, look, we have to do this. We have to update these, and we have to get traction and change this with all the contemporary data that we now have available. And one astute executive council member challenged me and said, well, what makes you think you'll be successful when others have tried and failed at this in the past? And it's a fair question. I mean, other past presidents, people far more known in the field internationally and nationally than myself, had tried this and failed. So what was to think that I would be any different? And my answer to that was, it was going to be a grassroots effort. It wasn't going to be about Kothari. It wasn't going to be about the authors. It wasn't going to be about the city where the guidelines were created. It was going to be none of that. It was going to be a grassroots effort that once we had the guidelines, we were going to empower our members with this information to do battle against the various health plans. And what I have shown here is a diner in Iowa. So when that question was posed to me at the retreat, I said, how do you get a Clinton, an Obama, a Bush in the White House? How do you go from anonymity to presidency? It starts with this diner. And this is the diner in Iowa that any presidential candidate goes to meet people, shake hands, cast their vision, and get their vote. And so that was my response, which was, this will be grassroots. This will be member led. And so, in addition to that, at the time then on the Clinical Issues Committee, we had Dan Eisenberg as the chair, and a gifted surgeon scientist, thoughtful, respected, and evidence-based. And I commissioned him to create a team to put this together. And I talked with him that in my head, I knew where we wanted the guidelines to go. I knew we wanted to talk about age barriers. We wanted to talk about the patients of Asian ethnicity. We wanted to know bridge to other procedures. We had to get that data in there about the lower BMI, particularly around the type 2 diabetic. So that's what I charged him with. And then he put this amazing, gifted, evidence-based writing team together to look at the evidence and begin writing this up. And we were well on our way with the different writing groups. We had board approval, and off we went. And then when I was president, as many presidents of ASMBS are, they're invited to speak at different various courses. Dr. Shakura invited me to speak at his course in Boston. And while we were having dinner, I told him about my vision. It's time to update the guidelines. And he said, well, I'm thinking about updating the guidelines as well with IFSO. Now we were at a crossroads because we don't want competing guidelines, because that will just be used as ammunition against us from the health plans. And we've seen that with some guidelines from ASMBS and IFSO that particularly maybe around endoscopy as an example, they don't quite align. And there's times where that's okay. But when something as important as our new indications and guidelines for metabolic bariatric surgery, we have to be able to create a unified front. And so by the end of that dinner, we had agreed that I would take it back to my executive council and he would respectively, that we would work collaboratively on this project rather than competition. And so even though our item writing groups were already created, I went back to Dr. Shakur and he provided names, and we added IFSO representation to each one of those sub-writing groups of the guidelines. And throughout the course of that year, they were written. We, in essence, no longer wanted to reference the old guidelines. And through this amazing collaborative effort, was able to create the 2022 ASMBS and IFSO indications for metabolic and bariatric surgery. Now, we're going to start unpacking all of the changes within these new guidelines over the next several talks. So I'm not going to spend time doing a deep dive on that. I do put this up here just to show this reference that there is this great fact sheet that is available online on our website that shares, the changes to them. And this is a great thing, particularly for our folks on the front lines in primary care who deal with the patient suffering from the disease of obesity, to kind of just give them a primer if they don't have the time and luxury to read the entire guideline article. The other thing that we felt very passionate about, Dr. Shakur and I, was making this open access. So this was available to anybody. We did not want any financial barriers to saying, pay $35 to download this article, things of that nature. Not everyone has the privilege of working in a more academic environment where they have access to a university library and things of that nature. We wanted anybody around the world to be able to have access to these guidelines, to empower them through whatever their local plans are that they were fighting, whatever the kind of health model that they were in and whatever country that was in, to be able to have access to these. And we co-published them in SWORD as well as Obesity Surgery. So the two premier journals of ASMBS and IFSO respectively, simultaneously. So if you didn't have access to SWORD, but you get obesity surgery, you would have access to them and vice versa. And we wanted a big push to begin to reference these. One of the things about the NIH guidelines is it was a self-inflicted gunshot wound because we kept publishing in all of our methods of all of our papers. We'd say all of our patients met the 1991 NIH guidelines. No, we want to quit seeing that in methodology of your papers, and so much so that we don't want the editorial boards of our two respected journals even accepting articles that reference that. We wanted them to start using these new guidelines moving forward. One other thing we have available, which is kind of neat, is this little video. And so I believe it's available on our websites. It might even be, I think it's available maybe perhaps even on YouTube. But nevertheless, it just kind of is a visual abstract, but it's an interactive one that kind of just gives you a primer. Any one of you who might be giving a talk can use this in your talk to walk through the new indications that we have expanded. Again, here we are talking about the changes and threshold from Asian ethnicity. Here we are talking about the frailty index that we use. We don't discriminate just on chronologic age anymore. Obviously, a lot of literature now around the children and adolescents and how we came up with that. And then, of course, we have unique populations, and the bridges to joint replacement, ab wall hernia, as well as a bridge to organ transplant, a really emerging field as well. And then there's those that we years ago we just said no. And now we know. Look at these: BMI greater than 60, patients with cirrhosis, and even LVAD bridge to possible heart transplant. That there's benefits of metabolic bariatric surgery based on best evidence. So this is a great little tool that's available that you can use. Maybe have it rolling in your various slide presentations that you give, or maybe even you want it on a jumbotron out in your waiting room or something like that as well. Another useful resource we have available, and it's a short video available on YouTube, is a summary of the guidelines that are done in a visual abstract form, but real time. This is just an example because I can't share the video per se. These are just representative screenshots of what this looks like. If you were to download and use this, you can use this in an informational seminar. You can actually use it in talks that maybe you will be giving on this topic as well. And then came the dissemination. So here was an example of IFSO putting on this to the world, the rolling out of the new guidelines that we saw spearheaded here again by our respected members of IFSO. And I love this picture. Of course, I screenshotted it and took it off of the live off the video cast. But I love the picture of Dan Eisenberg. It's just kind of a little, yeah, we just did the guidelines picture of him, and I thought it was kind of, for a guy who's so humble and such a servant leader, I needed a picture that kind of showed that he was proud of this accomplishment as the first author on this monumental achievement. And then came the dissemination. So there's a website called Guideline Central that I wasn't even aware of. But you go online, you type in guidelines, up pops our indications for metabolic bariatric surgery. Shows the key takeaways and the conclusions of these new guidelines. If you click on the video tab as seen right there, what's it going to take you to? It's going to take you to the integrated health unpacking of the guidelines when they were first released as well. There's so much rich data in here, and there's reasons we're having webinars and obesity summit like this one is to unpack all of this rich data through the respective lenses of all of his various specialties in medicine and surgery and how it impacts our patients. And so that's available as well. There are people that are even at arm's length that aren't really actively involved in the ASMBS. There's an Apple podcast by this individual breaking down the guidelines and talking about these. And then this is actually available on YouTube. It was a live international broadcast. It was very well done. It's only about 3 minutes or so, but you can look at if you go on YouTube. Powerfully done. That was given shared with the world about the ASMBS IFSO guidelines and the basic fundamental changes. Very well done 3-minute news article on that. We did get a lot of traction. This is just a small summary of a snapshot of the various news outlets that ran with this. But we were also prepared by working with Roger Kissin, who is our media manager behind the scenes. And once this kind of blew up and we were ready for our guidelines because we were prepared with our statements and ready to go when this hit the ground, we can see that it was about 1.1 billion views in terms of all of the various outlets that these were released to was picked up by this. And so that's pretty amazing achievement in and of itself from a dissemination standpoint of something so monumental as our new guidelines. I was really excited to see if you typed in this case, IFSO 2022 guidelines, it's the first thing that pops up under a Google search. If you used to just type in guidelines, it would used to say the NIH guidelines would be the first thing to show up, those historic things. So this is encouraging. If you type in weight loss guideline indications, again, what's the first thing that pops up? The article published in SWORD on our guidelines. So this is how we begin to turn the tide and begin to not only move these things to the top of the search engines, but begin to change the way we approach our patients. And ultimately, as we know, it's about expanded coverage for our patients from our payers. So again, what did we talk about? We want this article referenced in our articles moving forward. Great to see if you type in weight loss surgery indications, it's the #2 article that pops up. Wish it was #1, but that's okay. Nothing against dear Bruce Wolf, who shows up as #1. He deserves that with all of his contributions as well over the years. And what did I talk about? We wanted it to be in the publications. We wanted this to be hardwired. Abandon the reference to the NIH guidelines and look at this. Well over 250 publications since our guidelines have been published already to date in this short amount of time. And they're referencing these guidelines in our 2 respective journals. And so that's great to see as we continue to just drift away from the historic, antiquated 1991 guidelines. One of the benefits for our membership was something that was one of my presidential initiatives was to have this platform called Doc Matter for our membership to have discussions and you can see over 13,000 discussion views amongst our membership generating buzz around the new guidelines here as well. But most importantly, it's things like this that bring a smile to my face and give me true satisfaction. At this stage of my career, there's very few surgeries that I can do that when I get done, I'm like, that really was satisfying. But now as my career has matured, it's things like this. In one of our social media platforms where somebody's talking about they just had a peer-to-peer with somebody and they got the appeal overturned because of our new guidelines. This is an amazing win. And it started with this one patient and somebody posting about it. And I love how that person, then she wrote, the doc on the other end of the line on the peer-to-peer said they have to admit the guidelines came from a quote-unquote reputable source, laugh out loud. So this was the tip of the iceberg. Can we start to get the health plans to fall into line? And the answer to that is yes. Working with our access to care and some of our industry partners and tracking of this data, you can see a recent report from Renee Hilton, who chairs our access to care, amazing individual who's so passionate about improving access to care for our patients. Health partners, 394,000 covered lives, just came into alignment, adopting some of our guidelines, expanding indications. Fantastic to see. And just this past week, on Wednesday, January 24th, another email from Dr. Hilton to the Access to Care Committee. Guess what? UPMC, 1.5 million covered lives. That's a large health plan. Just adopted many of our guidelines. Here we are. You can see them coming into line around the Asian ethnicity, about the BMI with or without comorbid conditions as well. And then, of course, the type 2 diabetic in the 30 to 35 range. Pretty amazing to see wholeheartedly carte blanche adoption of a large health plan, 1.5 million covered lives now. Think how many patients are going to suddenly overnight qualify under this plan for that which we have known for many, many years. I wanted to highlight this last year at the ASMBS. And so, again, to give a shout out to Dr. Eisenberg and all the other co-authors who did so much work on this. And then my partner in crime, Dr. Shakora, I wanted to highlight, even at that time, the plans that were coming online, adopting and changing their policy based on the new guidelines. And so we had this poster up at the ASMBS last year as well. Now, it wasn't all a bed of roses. Somebody wrote back to Obesity Surgery and were actually deeply disturbed at our guidelines because they didn't talk about anti-obesity medications. They didn't talk about all of the steps that we do prior to surgery in terms of offering patients non-surgical interventions. to which Drs. Eisenberg, Shakor, and myself wrote a thoughtful letter back in response to said individual. As you can see in that first paragraph, basically that wasn't the purpose of this. ASMBS has a separate article just on a review of all the anti-obesity medications, and absolutely they have a role. And it wasn't talking about all of the integrated health colleagues and what all of you guys have a separate guidelines and a massive publication on that we abide by as well. So nevertheless, this was just our thoughtful rebuttal to somebody who was concerned about that as we move forward. But this is not the end. Ladies and gentlemen, this is really just the beginning. And some of our international colleagues in the IFSO camp were concerned that when we were about to release these, that we did not go through and grade levels of evidence for each of these individual areas. And now that's a big project. I mean, it was evidence-based, but we didn't grade the levels of evidence in these new guidelines. And so we felt that that was actually a separate paper. And that's a separate paper that's been happening behind the scenes now for since we released the 2022 guidelines. And here you can see the various leads from IFSO and ASMBS behind the scenes. And this has been a gargantuan project to try and get over the finish line. And we eventually will do it, and we'll probably publish this, obviously, is the goal as well, to show the methodology and the levels of evidence behind all of the the guidelines that we have as well. So that is something to just stay tuned for. But it's really important. We got to keep our foot on the gas, and we must continue to leverage this with all of our various partners. Obesity Action Coalition. We need to continue to keep the guidelines in front of them and let them work for their patients as well. Because, when we do it, the plans think it's self-serving, that we have the benefit from it. But it's actually to the benefit of our patients. And so when we empower the Obesity Action Coalition, that's very helpful as well. We work with the Stop Obesity Alliance as well. Many of you may be members of this, or your societies are as well. A powerful organization that we partner with to continue to keep our message out there in front of the providers and payers alike. And then on the ASMBS side, we have a PAC, and it's important to give to our PAC. We know that to get in front of the key stakeholders, you got to pay to play, and you have to give money kind of to both sides of the aisle, so to speak, to keep this mission forward. We actually have a state chapter lobby day grant application. Sadly, I now live in South Carolina, one of the 3 states where state employees cannot get coverage for bariatric surgery. And so we are going to continue to work on this, not only nationally, but on the state employee level coverage. And it gives us a chance to not only flip the state of South Carolina and the remaining 2, but also when they try and flip them to embrace these more evidence-based guidelines. Now, again, we have, I mentioned Dr. Renee Hilton, an amazing individual who is passionate about advocacy. Her Access to Care team is absolutely amazing in terms of their passion around this. And we have, of course, Joe Northrup as our past chair and a liaison to the Executive Council, a wealth of information that he has around that. And we all work with, regardless of the many societies, including ASMBS listed there, with Chris Gallagher, our Washington policy advisor, who keeps us abreast of where we are on TROA, the Treat and Reduce Obesity Act, which we haven't gotten across the finish line, but maybe again, we can continue to get traction with the new guidelines around this as well. So in conclusion, when you look from 1991 to where we came in 2022, we in fact had a burning platform. And the reason it did get successful as opposed to the failures in the past, perhaps, are these things that I've listed here upon reflection. I got ASMBS Executive Council approval rather than going it alone. So we started with board approval rather than trying to get board approval after the fact. Then we worked collaboratively rather than competitively with our international colleagues. And that was an important step as well. We did dual publications in our respective journals. Then we were prepared for the media release. So we had our talking points and be able to get those sound bites ready to go. And you saw the fruits of that labor in the slides I presented earlier. And then the important point, it was never about any one individual. This wasn't about a Dan Eisenberg or a Shanu Kothari or a Scott Shakor or any of the other authors. This was truly a grassroots effort. And we've seen that with the wins at the local level when our members have been winning these peer-to-peers, and we're seeing these health plans fall into line now as well. So even though this picture during my presidential reception, a little tongue-in-cheek, but nevertheless, with all of the past and the future president shown there, although I'm on the ground, I have really lived on the shoulders of these giants. And then when I reflected on this picture, I noticed Bruce Wolfe, one of the past presidents, in this picture as well. I often think, what does he think now? After he's seen from the 1991 to the 2004 to the 2013, where he was the lone surgeon present there, to now we are with the 2022 guidelines. The evolution of our field and now our guidelines and seeing the health plans come online, that must be something really special for somebody who was there during the darkest of days in our specialty as well. And like I said, it's not about me. It's been about our members. It's not only our ASMBS surgeons. It's working with Karen and other members of our integrated health team. It's working with our ASMBS staff. It's working with Renee and that amazing Access to Care team and those else that are listed here. All of our friends and colleagues within the societies and respective societies, and even in our international colleagues as pictured here as well. And it's working together like this that a rising tide will raise all boats. And I'm really looking forward to the future, working collaboratively through other societies such as those that are sharing here at the summit. And I thank you so much for your attention.
Good afternoon, and welcome to the 2024 Integrated Health Obesity Summit. My name is Kellie Armstrong. I am the Service Line Manager for the Center for Bariatric Surgery at the Miriam Hospital in Providence, Rhode Island. Today I'm going to discuss with you indications for metabolic and bariatric surgery in relation to BMI and the Asian population threshold. In 1991, yes, 33 years ago, the National Institute of Health organized a consensus development conference where they reviewed and created a statement of GI surgery for severe obesity. The statement was developed and published. It was based on the medical knowledge that was available in 1991. The statement produced criteria of a body mass index greater to or equal to 40 or greater to or equal to 35 to 39.9 with comorbid conditions as a standard for patient selection in relation to the approval of metabolic bariatric surgery. This criteria since that time has been used by insurance companies, healthcare facilities, and providers ever since. Even though BMI is still the most widely used instrument to be able to identify and diagnose patients with being overweight and or the disease of obesity, there are limitations to the BMI, as being able to accurately risk stratify the disease of obesity. Metabolic bariatric surgery still continues to be the most effective and evidence-based treatment for obesity across all BMI classes. Since 1991, over 3 decades, there have been hundreds of studies that have been published throughout the world. These studies have led to obesity being recognized as a chronic disease and has also increased the understanding and the evidence-based treatment options. For example, even in the last 10 years, such as in June 2013, the American Medical Association voted to recognize obesity as a disease state requiring treatment and preventative efforts and measures. In 2016, 45 professional societies, including the American Diabetic Association, issued a joint statement that metabolic surgery should be considered for patients with type 2 diabetes and have a BMI of 30 to 34.9 if their hypoglycemia is inadequately controlled despite optimal treatment with either oral or injectable medications. This recommendation was also included in the 2022 American Diabetic Association Standards of Medical Care in Diabetes. In 2022, the ASMBS and IFSO combined together to issue a statement for indications for metabolic and bariatric surgery in which lists over 140 plus references. Class 1 obesity, which is your BMI of 30 to 34.9, is a disease that causes and can make worse multiple different medical and psychological conditions. It can decrease our life expectancy. It can also impair our quality of lives. Prospective and large retrospective studies support the notion that metabolic bariatric surgery should be considered a treatment option for patients with class 1 obesity. These patients who do not achieve substantial or durable weight loss or their comorbid conditions do not improve with non-surgical methods. There are early findings prompting international diabetes organizations to have published a joint statement supporting the consideration for metabolic bariatric surgery in patients with BMIs less than 35 and type 2 diabetes. There are randomized trials designed specifically to study the population with BMIs less than 35, who also demonstrate significant benefits from metabolic bariatric surgeries in individuals with the class 1 obesity compared to other treatments. There are also randomized controlled trials of 80 patients with BMIs of 30 to 35 assigned to non-surgical treatment or metabolic bariatric surgery. These trials demonstrated that patients undergoing metabolic bariatric surgery had superior long-term weight reduction and improvement of metabolic diseases. A short-term follow-up randomized trial examined patients with type 2 diabetes, and it demonstrated significantly improved remission of diabetes and weight loss in those individuals undergoing metabolic bariatric surgery compared with metabolic medical weight management. There is a lot to show that medical weight loss is considered to have greater durability in individuals with BMIs less than 35 than those individuals with BMIs of 35 or higher. Because of this, it is recommended that a trial of non-surgical therapy is to be attempted before considering surgical treatment. However, if these attempts at medical management of treating the disease of obesity and the obesity-related comorbid conditions, such as type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, polycystic ovarian syndrome, infertility, GERD, pseudotumor, cerebri, and bone or joint disease have not been effective, then metabolic bariatric surgery should be considered for suitable individuals with class 1 obesity. There is presence of high-quality scientific data that show the safety and efficiency of cost-effectiveness of metabolic bariatric surgery in improving survival, quality of life in patients with BMIs of 35. Metabolic bariatric surgery should be strongly recommended in these patients regardless of presence or absence of evident obesity-related comorbid conditions. Currently, non-surgical treatment options for patients with BMIs are ineffective in achieving a substantial and sustainable weight loss or weight reduction necessary to significantly improve their general health. Physical problems related to excess body weight, undiagnosed obesity-related conditions, risk of developing obesity-related comorbidities in the future, and impaired quality of life related to physical, mental consequences of obesity threaten to the general health of individuals with moderate to severe obesity, even in the absence of diagnosed obesity-related comorbid conditions. The ASMBS IFSO guidelines now recommend that metabolic and bariatric surgery for individuals with a BMI of 35 or more, regardless of presence, absence, or severity of obesity-related conditions, and that it be considered for people with a BMI of 30 to 34.9 and a metabolic disease in appropriately selected children and adolescents. But even without metabolic disease, the guidelines say weight loss surgery should be considered starting at a BMI of 30 for both people who do not achieve substantial or durable weight loss or have obesity-related disease comorbidities that are not improving by using non-surgical methods. It is also recommended that obesity definitions using the standard BMI thresholds be adjusted. One of those adjustments would be by Asian ethnic background, and that Asian individuals should consider weight loss surgery beginning at a BMI of 27.5. The World Health Organization defines overweight and obesity using the standard BMI thresholds. BMI, although, does not include factors such as ethnic background, age, sex, or their body's fat distribution. The Asian population has a greater risk and higher prevalence at a lower BMI for diabetes and cardiovascular diseases than non-Asian populations. We need to adjust the definition of obesity in Asians to have a BMI of 25 to 27.5, and an Asian individual should consider weight loss surgery beginning at that BMI of 27.5. This then would remove the risk of denying access to metabolic bariatric surgeries to specific populations, as it is based on data that is 33 years old, based on the original BMI threshold criteria. Here is a list of the references that I used today. Thank you for allowing me a few minutes of your time so that we can review the 2022 American Society for Metabolic and Bariatric Surgery and the International Federation for Surgery of Obesity and Metabolic Disorders indications for metabolic and bariatric surgeries related to the BMI in the Asian population. Please feel free to reach out if you have any questions. My contact information is at the bottom of the slide. Again, thank you and have a wonderful afternoon.
Hi again, this is Karen Flanders, and I am sharing a presentation with you about the specific recommendations from the ASMBS IFSO's indications for metabolic and bariatric surgery, but very specific to extremes of age regarding the older population and pediatrics and adolescents. I do not have any disclosures or conflicts of interest to share. Let me start by asking the question, is there an age limit with metabolic and bariatric surgery? How old is too old? Based on available data and septuagenarians, metabolic and bariatric surgery is associated with slightly higher rates of postoperative complications compared with a younger population. But metabolic and bariatric surgery provides substantial benefits of weight loss and remission of comorbid disease. In the presence of obesity comorbid disease and the choice of operation are more predictive of 30-day adverse outcomes than age alone. Additionally, the physiologic changes that occur with aging may have an impact on the efficacy of metabolic and bariatric surgery, the incidence of postoperative complications, and the ability of older patients to recover from surgery. However, it appears that factors other than age, such as frailty, cognitive capacity, smoking status, and end organ function, play an important role. So is there an age limit with metabolic and bariatric surgery? Well, frailty, rather than age alone, is independently associated with higher rates of postoperative complication following metabolic and bariatric surgery. Furthermore, when considering metabolic and bariatric surgery in older patients, the risk of surgery should be evaluated against the morbidity risk of obesity-related diseases. And so there is no evidence to support an age limit on patients seeking metabolic and bariatric surgery, but careful selection, including assessment of frailty, is recommended. Here are two examples of frailty indexes. The CSHA, based on a Canadian study of health and aging, and the other through the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. Both score frailty by associated factors, such as functional status. Is the patient dependent or independent in their care? Can they feed themselves, dress themselves, get ready themselves, carry out personal grooming, cooking? Mobility. Are they limited in their mobility? Do they need a walker, a cane, or any other assistive devices? Are they wheelchair bound? The presence of or history of diabetes. Lung problems such as history of chronic obstructive pulmonary disease, need for oxygen or obstructive sleep apnea. Is there any history of a heart attack or cardiac problems such as previous cardiac surgery or percutaneous cardiac intervention? High blood pressure requiring medication. Are there any gastrointestinal or abdominal problems, such as gastroesophageal reflux disease, requiring medication? Or any other medical history, including renal insufficiency, or are they on dialysis? Changing gears now, and at the other end of the age spectrum, we have pediatrics and adolescents. How young is too young? When looking at the impact of metabolic and bariatric surgery, it has been noted to produce durable weight loss, improve comorbid conditions, and is safe in the population under 18 years of age. The American Academy of Pediatrics and the ASMBS recommend consideration of metabolic and bariatric surgery in children or adolescents with a BMI greater than 120% of the 95th percentile, or class 2 obesity, plus a major comorbidity, or with a BMI greater than 140% of the 95th percentile, or class 3 obesity. Metabolic and bariatric surgery does not negatively impact pubertal development or linear growth. Therefore, a specific Tanner stage and bone age should not be considered a requirement for surgery. Increasingly, syndromic obesity, developmental delay, autism spectrum, or history of trauma are not considered contraindications to metabolic and bariatric surgery in adolescents. And since the publication of the ASMBS IFSO indications for metabolic and bariatric surgery, the American Academy of Pediatrics have published clinical practice guidelines in which it is recommended that for eligible patients with severe obesity to offer a referral to a local or regional comprehensive multidisciplinary pediatric metabolic and bariatric surgery center for surgical evaluation. To summarize, there is no upper age limit to metabolic and bariatric surgery, and older individuals who could benefit from weight loss surgery should be considered for surgery after careful assessment of comorbidities and frailty. Nor are there specific lower age recommendations, but rather a recommendation for children and adolescents meeting the BMI recommendations to be considered for metabolic and bariatric surgery after evaluation in a specialty center by a multidisciplinary team. I thank you for joining us today for this Obesity Summit. I share with you my resources, and I open up for any questions anyone may have. Thank you again and have a good day.
Good afternoon, everyone. I'm Michael Dougherty, and I'm a physician assistant from Abington Jefferson Health in Abington, Pennsylvania. Today, I will be discussing metabolic and bariatric surgery as a bridge to other treatments, specifically joint arthroplasty, abdominal wall hernia repair, and organ transplantation. I have no financial disclosures and no industry representation to note at this time, but as always, if anyone knows anyone, please let me know. In reference to metabolic and bariatric surgery as a bridge to other treatments, what will be discussed here today? Very broadly, we'll be discussing the who, the when, and the why. Let's get started. The educational focus for this lecture will be mainly focused on the 2022 ASMBS and IFSO Indications for Metabolic and Bariatric Surgery article. So why metabolic and bariatric surgery? As previously mentioned, metabolic and bariatric surgery in this case, will be acting as a bridge. Or, in other words, acting as a pathway. A pathway to what? And a pathway for patients' improved health, and a pathway for improved opportunities. The key features of this presentation and each subheading will be focused on patient safety and patient success and satisfaction. First up, we have joint arthroplasty. There will be common themes throughout this presentation in reference to obesity, most particularly Class 2 and Class 3 obesity being the main patient base. Respectively, BMI of 35 to 39 for Class 2 obesity and a BMI of 40 or greater for Class 3 obesity. Patients in need of total joint or spine surgery are the population for joint arthroplasty that will be focused on here. When is the time to have metabolic bariatric surgery in reference to joint arthroplasty? Studies have shown that having surgery greater than 2 years prior to the total joint surgery is the best time for patients. This will allow for time to maximize weight loss, as well as offering reassessment of joint needs. Next, we have why. Now, throughout this presentation, when it comes to why, you'll see a common theme related to two aspects. One, why is obesity a relative contraindication or challenge for any treatment? And two, why is metabolic and bariatric surgery a proper bridge? Now, these are often inseparable or linked, but I will do my best to distinguish here. Obesity can lead to increased technical challenges. Those technical challenges can be broad and related to the patient's comorbidities that they come in with, such as hypertension, obstructive sleep apnea, diabetes, and they can also be specific to the treatment. So in this case, patients with obesity have an increased amount of subcutaneous tissue, which will make it an impedance or barrier to access the joint itself and replace it. There can also be increased hospital readmission rates. Now, these readmission rates can be related again to the comorbidities that the patient comes in with and are exacerbated, or they can be related to postoperative surgical complications. When it comes to joint arthroplasty, specifically wound infections related to that subcutaneous tissue, as mentioned, or the joint itself, and then also deep vein thrombosis, as any surgery has a heightened increase in blood clots, and obesity even more so. Now that's part one. Now part two to the why is bariatric surgery, metabolic and bariatric surgery, a proper bridge? Well, after significant weight loss, there is a decrease in operative time, there is a decrease in length of stay, and a decrease in early postoperative complications. Now, to be transparent, it has been shown that later complications with joint arthroplasty are relatively unchanged, but the early postoperative complications, as mentioned above, such as wound infections and deep vein thrombosis, are much lessened with the weight loss. Now, not in the ASMBS IFSO 2022 article, but instead found this nice little diagram in the Journal of Bone and Joint Surgery. Kind of reinforces the points from that article in a very broad way, is that the difference between a patient of class 1 or class 2 obesity as opposed to a patient with class 3 obesity does have a higher complication risk and the need for risk of revision, as well as, as you can see from the numbers, an increased risk of infection, and particularly they're pointing out here joint loosening. Next, we have abdominal wall hernias. The WHO remains the same, with class 2 or class 3 obesity being the focus, and in particular for abdominal wall hernias, patients who have large and or chronic hernias. The when of repairing an abdominal wall hernia in relation to metabolic and bariatric surgery remains controversial, just as with joint arthroplasty. Abdominal hernias are still repaired and performed amongst obese patients, and is not a be-all to end-all obesity and repairing hernias. But evidence shows that a staged procedure to definitive hernia repair is best for patients. Now the why. So in relation to abdominal hernias, there has to be consideration that there is a larger volume of subcutaneous or soft tissue amongst the obese. This can lead to many problems. Increased risk of impaired wound healing, there's an increased risk of local and systemic infections, and there's an increased risk of hernia recurrence. Not to mention the increased complexity of the repair itself, as hernias in obese patients are typically larger, and then there has to be considerations for the materials needed, the length of surgery itself, and the difficulty bringing those structures together. So with all of these in consideration, as I mentioned before, the commonality of two aspects of why is metabolic and bariatric surgery a good bridge? The obvious answer here being that all of these aspects are decreased with weight reduction and using metabolic and bariatric surgery for that weight reduction. The reduction of subcutaneous tissue will lessen the chances of wound infections, systemic infections, and a hernia recurrence, as those structures can be brought together more easily as well as more securely. There's also a reduction in the materials that would be needed. Now, the hernia is the hernia, and the size of which may or may not change, but the structures can come together easier and may need a smaller or less mesh. Overall, the premise being that weight reduction from metabolic and bariatric surgery as a bridge can lead to a better, safer, and longer-lasting hernia repair. Organ transplantation. Now, the WHO remains relatively the same. We are still speaking of a population of class 2 or class 3 obesity, and in this case, class 3 obesity is often associated with end-stage organ disease, and in turn, patients in need for transplantation. The difference here between joint arthroplasty as well as abdominal wall hernia is that in those cases, even in the face of obesity, those surgeries can oftentimes still be performed, though maybe not optimized, and why bariatric surgery acts as a proper bridge for the most success. In the case of organ transplantation, however, obesity can often be a limitation or a barrier to getting an organ transplantation. Patients often denied or not in any way eligible for an organ. So, when should a patient get organ transplantation? When should a patient get bariatric surgery in reference to organ transplantation? Now, studies have shown, and the article alludes to, that bariatric surgery and metabolic bariatric surgery is often overlooked as an option in patients with end-stage organ disease. Now, whether it's a bias or not a consideration was not clearly stated, but insinuated that patients are of not a healthy enough state to have organ transplantation, so maybe in their obese state are not acceptable for bariatric surgery, which is not often the case. With the proper workup and clearances, it actually improves their candidacy for organ transplantation, so metabolic and bariatric surgery are a very good option for the obese population in need of organ transplantation. Even to the point where the article states that greater than 50% of patients with end-stage renal disease will be eligible within 5 years after metabolic and bariatric surgery. So why do we use metabolic and bariatric surgery as a bridge to organ transplantation? Again, all caps here, obesity is a relative contraindication for solid organ transplant. That can be kidney, liver, and the heart. Now, in reference to a kidney, it is very concretely stated that it is not recommended a kidney transplant in a patient with a BMI greater than 40. There is evidence that there is delayed graft function and multiple wound complications after renal transplant with a patient greater than BMI greater than 40. In terms of the heart, it is determined that metabolic and bariatric surgery is safe for patients with heart failure or left ventricular assist devices, or LVADs. A study of more than 2,700 patients showed a 3-fold higher rate of heart transplant after metabolic and bariatric surgery. And metabolic and bariatric surgery can increase left ventricular function even to the point that transplant is no longer needed. So it goes back to an earlier point of with even reassessment after a weight loss before joint arthroplasty, is that even in those patients who are in need of kidneys, livers, or hearts, that weight reduction can aid in possibly giving patients prolonged period of time to need an organ or not need an organ at all in the case of increasing left ventricular function. Again, as stated, this presentation focused on the 2022 ASMBS and IFSO indications for metabolic and bariatric surgery. My section being the bridge to other treatments, as shown throughout those three subcategories, that metabolic bariatric surgery should never be discounted as an option and can lead to improved patient outcomes and opportunities. Thank you for this opportunity. I look forward to hearing the other presenters and future discussions on this topic.
Hi, my name is Sarah Muntel. I'm a registered dietitian and bariatric coordinator from Indianapolis, Indiana. Today we'll be speaking with you on metabolic and bariatric surgery in the high-risk patient, specifically patients with a BMI over 60, patients with cirrhosis, and patients with heart failure. The new IFSO and ASMBS recommendations have been incredibly helpful for both providers and programs looking for guidelines on patient selection. So we do know now that carefully selected individuals considered high risk for general surgery may still benefit for metabolic and bariatric surgery. And the groups we're going to talk about today are patients with a high BMI, patients with heart failure, and patients with cirrhosis. These are the types of patients that often programs discuss and really take some time to determine if the risk of surgery is going to outweigh the benefit that they may have after surgery. And we have some great data to kind of show how these patients can benefit greatly from surgery without the risk that we once thought when we carefully select. So the first group that we're going to talk about is patients with a high BMI. So a BMI greater than 60 is the group that we're talking about today. So when we first think about this, we say, why is BMI a concern? So historically years back, we're looking at when the BMI is increased, so typically are the comorbidities that patient is going to have. So as the BMI goes a little higher, they're going to have more likelihood to be diabetic or have sleep apnea or have hypertension, which is going to definitely increase their risk. We then also know that often when the BMI goes higher, a lot of that abdominal adipose tissue is in that abdominal area, which is going to make surgery a little bit more difficult for our surgeons. And then we see increased morbidity, so there are higher risks when the BMI goes higher. We know that as well. And then these patients sometimes can be in the hospital a little bit longer. So that's been the concern historically, and really why programs kind of shy away sometimes with those higher BMI patients. But there's some great outcomes that I wanted to share with you today. So this is a review of readmissions, re-ops, and mortality rates as BMI increases. So this is about 2,700 patients that you see, and you see the categories of BMI of 40 to 50, 50 to 60, and greater than 60. So kind of in 3 different subgroups. And if you scroll down the columns, you will see that the overall readmission rate, reoperation rate, and mortality rate are listed there. As they do get a little bit higher as the BMI goes, above that 60, they are still, well within, 1% and still considered a safe operation. Going even a little bit higher, this is, say, an ACS-NSQIP database, and this is looking at patients who have a BMI greater than 70. So we're even going above that 60 and going a little bit higher. And looking at a couple different things like mortality, DVT, and length of stay. So you see that there is a difference in mortality rate and DVT and length of stay when we look at those higher BMIs. However, they're still within a low range and still an optimal range for surgery. One more, just to show you, would be this. This is from our MBSAQIP database, which is our quality program that all bariatric programs, or most bariatric programs, work with to maintain quality standards. So 350,000 patients, and we're looking at 3 categories. So a BMI of 35 to 50, 50 to 60, and 60 to greater. And we look at those patients that had any complication and then looking at their mortality rate. And this is divided between gastric bypass and sleeve gastrectomy. And again, we see that as the BMI goes higher, that there is an increased risk, but it is still within a normal range. I think the biggest question and the biggest reason that we need to think about when we're looking at high BMI patients is really the main goal that we have here is resolution of comorbidities. So when patients have a higher BMI, they still have a great resolution in the things that we are trying to improve the most: type 2 diabetes, hypertension, sleep apnea, hyperlipidemia. So if you look at the visual here, we see patients who have a BMI greater than 50 in the dark gray, and the light gray is a BMI less than 50. So we see resolutions in all areas of all the different comorbidities in both categories. So looking at diabetes, type 2 diabetes, almost 50% resolution at 1 year, and looking at all the different areas there, we're seeing great health improvements, which again is a reason why we are choosing to do bariatric surgery. When we're looking at high BMI, there are some things that we do need to consider programmatically. Equipment is important, so we do want to think about equipment needs such as beds, wheelchairs, toilets, making sure that the standard beds are 500 and making sure that you have a bariatric equivalent bed, making sure you have the wider wheelchair so the patients can comfortably fit. The toilet should be floor mounted for patient safety. Location can also be an issue as well when we look at wheelchair access in lifts and doorways. In one of our programs, we were looking at a clinic space and found quickly that we couldn't maneuver kind of a wider wheelchair through the small hallways. So there's things to think about also. Coordination of care is important. There's other specialties that you want to take a look at. You're wanting to look at pulmonary and their endocrinologist and making sure that everyone's working together for a safe outcome. I think selection is important. In our practice, we have our more senior surgeons and then we have newer surgeons out of fellowship. Our more senior surgeons are going to take those higher BMI patients because they are going to be a little bit more challenging, so that can be another option as well. Another thing that we want to look at is metabolic and bariatric surgery with heart failure. So metabolic and bariatric surgery can be an adjunct treatment in patients with obesity and heart failure, sometimes before heart transplant to get them down to a specific BMI, before an LVAD. And then we often know that weight loss will reduce comorbidities and improve overall health and reduce future cardiac therapy. So there's a lot of reasons why, as we know, weight can improve overall cardiac health. However, what's the risk and what are we looking at? So here is a systematic and meta-analysis patient with end-stage heart failure. And just to know that you do need to have a BMI over 35 as a contraindication for heart transplant. So that's kind of a goal that a lot of our patients are going to be striving to. This is an N of 98 patients, so not a lot, but to kind of give you an idea. So basically, the pre-op, you're looking at least a 26% reduction on post-op BMI, so that's getting those patients under that 35. From there, 71% were listed on the heart transplant list, and 57% actually received a heart transplant. So what a great percentage. The mortality 30-day was 0, and the 30-day complication was 28. So there are complications there, but we look at the greater results. Additionally, looking at LVAD, so this was 2,700 patients who had an LVAD between 2012 and 2019. Of those 2,700 patients, where there's an increased risk, obviously, with cardiac and obesity, 198 had bariatric surgery during or after the LVAD placement. So what we see is their mortality scores and their MACE scores and their 30-day and 1 year are listed there. I think the bigger issue is we do know that there are complications, but the heart failure readmission burden declined. Of those 198, 37 total had a heart transplant and 13 had an LVAD explant. So as the weight comes down, those cardiac problems also decrease. These are heart-related outcomes, not bariatric. So we have a case group, a control group, and another control group. So all of these patients were heart failure patients with a history of bariatric surgery, and these were mortality from cardiac admissions. So the case group are the groups that had bariatric surgery. Control 1, which is the darkest, had a BMI greater than 35 with no history of bariatric surgery. And then control 2 is just kind of a mix of all different BMIs. So what we find here is if you look at the mortality rate on cardiac admissions after bariatric surgery, there's a 50% reduction in hospital mortality, which is a great reason as well. Program considerations, and I do think there are several. Our bariatric program does specific, LVAD patients and so on as a practice. We do consider hospital resources and surgeons. They do go to one of our specific hospitals that has the things that they're going to need cardiac-wise as well as metabolic and bariatric surgery-wise. We have one specific surgeon in our practice of 7 that does specifically do these patients because she feels she has more of the expertise and she's very familiar with all the resources. The specifics are to work closely with the coordinators from other areas with post-op anticoagulation and other things that may arise. The sleeve is often the most often chosen just due to meds after transplant. And modifications of programs, definitely may need to exist on these special cases. So looking at, do they need, a different way to do their appointments? We do more of a pre-op. They get some special nutrition supplements before surgery because there tend to be higher risk as they're coming into this. So, you're looking at what do we need to do to make this as safe as possible, but we know that the outcome can be great. The last category we're going to talk about is obesity for patients with cirrhosis. So we do know that obesity is definitely a risk factor for fatty liver, NASH, and cirrhosis. With obesity, patients are 3 times more likely to increase their risk of liver decompensation with cirrhosis. And then we also know that metabolic and bariatric surgery is associated with improvement of NASH and regression of fibrosis. It may often be a bridge to liver transplant, might be the reason why we're doing this. So a couple things just to talk about this. So we have about 1,100 patients, and these are patients with NASH and liver fibrosis both. So there are 2 groups. There's a control group, and there is another group that underwent bariatric surgery. So split kind of in half, a little more on the bariatric surgery side. But we look over a 10-year time frame, and then we look at major liver adverse outcomes. So if you see the orange line, the non-surgical control, and then we look at the bariatric surgery line, definitely less outcomes following bariatric surgery. So we noted improvement. Patients with cirrhosis, I think patient selection is very important. There's a systematic review of 21 studies on patients with cirrhosis, so a very comprehensive review. We do see that gastric sleeve is typically the most performed in patients with cirrhosis. Always surgeon's choice, but that's what's often chosen. Could be, we do know that laparoscopic sleeve gastrectomy is definitely the most common nationwide, which could affect. Also, there's preserved access to the stomach. With that, we also know that there's a higher rate of decompensation with malabsorptive procedures. So not often would a duodenal switch come into play with a patient with cirrhosis. What do the outcomes look like? So these are complications, again, in this study review of complications, mortality, and then liver decompensation. So comparing the gastric sleeve with the gastric bypass. So the complication rate is higher with the gastric bypass, the mortality is higher, and the liver decompensation is pretty similar, which means, which is kind of one of the reasons why patients or providers typically go with gastric sleeve. Here's some, this is a great visual. So we look at 180 patients with NASH and bariatric surgery. With this, looking at kind of that first slide, and this is after with a BMI loss of greater than 10 kilograms. NASH was resolved without worsening fibrosis in 84% of patients. So we're looking at, the light blue is resolution of NASH without fibrosis worsening. So that is greatly improved. We looked at fibrosis is decreased compared to baseline in samples from 70% of the patients. So you look at baseline, 1 year and 5 years, and the white there is actually a score of 0. So you see a great improvement up to 56%. So, and then resolution of NASH was observed 1 year after bariatric surgery and biopsies from 84% of patients. So seeing a great outcome with their health. Some things to think about, and what was recommended in guidelines were this. We're looking at making sure that there is a bariatric center with MBSA QIP access, and I think that really goes to speak with all of the high-risk patients that we choose to operate on. A pre-op evaluation is important as well to make sure that There's careful evaluation of portal hypertension and liver compensation to kind of see where that patient really is prior to bariatric surgery. Optimal procedure is again going to be a sleeve gastrectomy, including a surgical team and an anesthesia team with experience operating on patients with cirrhosis. So I thank you for your time today. Here are my references, and I look forward to speaking to you soon.
Hello, my name is Janelle Wilder Coughlin. I'm an associate professor and licensed psychologist at the Johns Hopkins School of Medicine, and I'm going to talk today about patient evaluation for patients pursuing metabolic and bariatric surgery. I have no disclosures. For my portion of the talk, I'm going to discuss the importance of multidisciplinary patient evaluation and summarize the components of multidisciplinary patient evaluation. My hope is, by the end of my talk, you'll be able to express why multidisciplinary care is important both pre- and post-surgically. Some questions you can ask yourself throughout my talk to facilitate your learning are, what is the value of a team-based approach? How can I think about the evaluation process as a critical component of patient care versus a checkbox? And how can I improve my interactions with patients to increase the likelihood that they will seek help and care after surgery? Multidisciplinary evaluation has been considered standard care for metabolic and bariatric surgery practice since 1991, when the NIH consensus statement emphasized the importance of multidisciplinary evaluation for patients pursuing metabolic and bariatric surgery. When we talk about the multidisciplinary team, we're talking about the surgical team, which often consists of surgeons, advanced practitioners such as nurse practitioners and physician's assistants, nutritionists and dietitians, behavioral health specialists such as licensed psychologists and social workers, and other medical experts who help patients proceed to surgery. The value of the multidisciplinary team remains a solid recommendation in the 2022 guidelines. Those who work in the field of obesity would agree that the support for multidisciplinary evaluation and care is particularly important in the care of those undergoing metabolic and bariatric surgery because obesity is a complex disease. The principle of weight gain remains simple. That is, weight gain occurs when energy intake exceeds energy expenditure. However, it is now well known that obesity is clearly the result of a complex set of interactions among genetic, biological, medical, behavioral, environmental, and psychosocial factors. The inclusion of a multidisciplinary team highlights the multifactorial etiology of obesity. A well-conducted team-based patient evaluation allows practitioners to provide a comprehensive risk-benefit analysis, to facilitate patients' ability to comprehend both the short and long-term changes before and after surgery, and to assess and manage patients' modifiable risk factors, which in turn decreases perioperative and long-term risks and improves outcomes. While ultimately the decision for surgical readiness primarily is determined by the surgeon, a team-based and thorough evaluation allows surgeons to assess patients' readiness from a comprehensive and multifaceted perspective. Pre-surgical requirements vary by insurance company and surgical program. Historically, there was enthusiasm for weight loss prior to surgery. However, research from multiple studies provide data that do not support the practice of insurance-mandated preoperative weight loss. In fact, this practice is generally understood to be discriminatory, arbitrary, and scientifically unfounded, and contributes to patient attrition, unnecessary delay of life-saving treatment, and progression of life-threatening comorbid conditions. Pre-surgical requirements continue to vary by insurance company and surgical program. Most require a pre-surgical behavioral readiness component. However, this has become more behaviorally focused versus weight focused, with the goal of decreasing patient barriers to surgery while also maintaining safety and readiness. Standard care for patients pursuing metabolic and bariatric surgery includes a nutritional assessment conducted by a registered dietitian with expertise in metabolic and bariatric surgery. These assessments allow dietitians to obtain a comprehensive weight and dietary history, to identify unique or maladaptive eating behaviors or patterns, to identify and address micronutrient deficiencies prior to surgery, and to provide preoperative nutrition education and prepare patients for dietary changes that are ahead and to reinforce changes that are already being made. Post-operatively, dietitians are also instrumental in assisting with the management of patients for things like adjustment to surgery, the progression of food intake from liquids to pureed, to soft foods to whole foods, the intake of fluids and proteins, the adjustment to food intolerances and changes, and to address malabsorption issues and micronutrient deficiencies as well as weight recurrence. There are several publications and guidelines to assist dietitians and those working with patients pursuing and who have undergone metabolic and bariatric surgery. Here I show the guidelines that were published in 2019 in endocrine practice that are widely used in the care of individuals pursuing bariatric surgery. Psychosocial evaluations are standard care in most surgical programs and should be conducted by a licensed mental health provider with a background and experience in metabolic and bariatric surgery. These evaluations allow the behavioral health provider to assess for psychopathology that could influence safety and outcomes, as well as to identify coping mechanisms and ability to engage in lifestyle changes required for surgery. And they also may be conducted to identify stressors that can impact outcomes, as well as barriers to care, such as financial, housing, and things like food insecurity. Psychosocial evaluations are endorsed by a number of professional societies, and as a field, we do not see these evaluations as being one of gatekeeping and keeping patients from progressing to surgery. Rather, we should see them as a process for identifying strengths and mitigating risks to help support patients as they pursue bariatric surgery. Here I provide a couple of resources for those who are interested in learning more about the psychosocial evaluation of individuals pursuing metabolic and bariatric surgery, both published in SWORD, one in 2016 and one in 2021. While the domains that are covered in psychosocial evaluations are many, some of the particularly important domains are the assessment of eating disorder symptoms, current and past mental health treatment, functioning, and psychopathology, and health-related behaviors like substance abuse, smoking behaviors, as well as self-harm and suicide. behavioral health providers should thoroughly screen for disordered eating behaviors, including binge eating, self-induced vomiting, and other compensatory behaviors, as well as overly restrictive dieting behaviors. And when appropriate, should refer to or provide evidence-based treatment, such as cognitive behavioral therapy, so that patients are equipped with behavioral strategies to improve outcomes and decrease risk. Research examining preoperative eating disorders and disordered behaviors, such as binge eating, as predictors of postoperative weight loss are mixed. Some show no association, and others show that preoperative disordered eating predicts less weight loss. When examining whether eating disorders persist after surgery, findings indicate that many disordered behaviors improve or change, for example, from binge eating to grazing with loss of control. Some completely remit, and other individuals develop de novo disordered eating behaviors. In general, post-operative loss of control eating, emotional eating, grazing, and evening overeating are associated with less post-surgical weight loss and weight recurrence, and are also of concern because of their association with psychological distress and worse quality of life. Therefore, post-operative assessment and intervention are particularly important to identify and address disordered eating behaviors and to identify patterns of behavior that may lead to less favorable weight outcomes and in some cases could lead to clinically diagnosable and life-threatening eating disorders. All metabolic and bariatric surgery programs should include an assessment of patients' alcohol use as well as education about pharmacokinetics of alcohol after gastric bypass and sleeve gastrectomy. This includes laboratory studies that have shown that individuals who have bariatric surgery and consume alcohol are at risk for becoming intoxicated faster, on smaller amounts, and for longer. It also includes cohort and longitudinal studies that have shown that patients who have had bariatric surgery are at increased risk for developing alcohol use disorders. Risk factors for post-operative abuse include being male, smoking, being of younger age, any or regular alcohol use, and a family history of substance use disorder. The ASMBS published a position statement on alcohol use before and after bariatric surgery for those wanting to understand research that has been conducted on this topic. All members of the multidisciplinary team can assess the 3 S's, that is, smoking, social support, and stressors. There is well-known and sufficient evidence that regular smoking of tobacco can increase odds of serious morbidity, death within 30 days of surgery, readmission, and longer hospital stays, as well as risk for marginal ulceration after gastric bypass. Therefore, providing resources for pre-surgical smoking cessation, such as intensive behavioral interventions and nicotine replacement, is essential. Assessment of social support including current living situation, quality of interpersonal relationships, and aftercare support plan is important. Qualitative data suggests that having a support network and making a joint journey is helpful. There is also evidence that attendance at post-operative support groups is associated with better weight loss. Assessment of the third S, stressors, is also important, and this includes stressors such as interpersonal challenges, work challenges, and financial challenges, as well as assessing patients' coping strategies. It's important for providers to realize that it's okay to ask patients, is this the right time for surgery? Providers working with individuals pursuing metabolic and bariatric surgery should understand that this is a psychiatrically vulnerable population with higher base rates of psychopathology. About a third of surgical candidates report depression at the time of evaluation, and about 10% report current suicidal ideation. Research has shown a positive association between obesity and suicide, and there's a greater prevalence of suicide history among those pursuing metabolic and bariatric surgery. We know that past suicide attempts are the strongest risk factor for future suicide deaths. Therefore, it is imperative that clinicians appreciate that depression and suicide are threats among those who have had bariatric surgery. Therefore, ongoing screening is important, and having a plan in place for safety is important. In summary, in all aspects of surgical evaluation for metabolic and bariatric surgery, including surgical evaluation, nutrition, and psychosocial evaluation, it's important to understand that evaluation and screening does not stop after the initial pre-surgical evaluation. In fact, ongoing screening and intervention is important post-surgically. Thank you for the opportunity to present. I hope you will use these questions to improve your practice, particularly as related to multidisciplinary evaluation, both pre and post-surgically. Coming back to the original questions that I presented, what is the value of a team-based approach? Hopefully, you have concluded that the team-based approach is at the heart of patient care. Instead of pushing patients through the system, you now see that evaluating patients critically leads to better weight, medical, and quality of life outcomes. Finally, it's important to remember that our thorough post-operative evaluation of patients is as important as pre-surgical and perioperative care. Is as important as pre-surgical and perioperative care.
Hi, my name is Carah Horn. I'm the MBS coordinator and research nurse at Bayfront Health in St. Petersburg. Today we're going to talk a little bit about the outcomes of metabolic and bariatric surgery. It's been shared throughout this summit that there is a myriad of conditions improved by metabolic and bariatric surgery. As we delve further into the associated health outcomes, it's critical to understand that obesity is about so much more than the scale. Obesity is an invasive, chronic, inflammatory disease process that can affect nearly every aspect of a person's life. The cause is not merely a caloric imbalance, and the effect certainly does not stop at total body weight. Obesity affects our patients' physical, mental, and social health. The disease burden is costly to the patient as well as to our healthcare system, and is statistically proportionate to both absenteeism and presenteeism in the workplace. When a patient delays or is denied access to treatment for obesity, their morbidity or mortality risk increase, tying directly to an increase in healthcare costs and impact on the workforce. The effects of metabolic and bariatric surgery are proven to reduce the risk of developing obesity-related comorbidities, improve existing comorbidities, and increase the quality of life for people battling obesity. Access to and utilization of evidence-based obesity treatment is imperative to the health of our patients and to society as a whole. While not the only variable impacted by metabolic and bariatric surgery, weight loss is a desired outcome that contributes to the reduction or resolution of associated conditions. Metabolic and bariatric surgery offers a treatment option for the disease of obesity that is superior in impact and durability to other approaches. Total body weight loss of just 10 to 15% has shown to affect associated comorbid conditions. And while some other methods have been able to produce these results, the trouble has always been sustainability. Diet and exercise alone may be impactful for people with overweight, but consistently fails to produce sufficient weight loss to affect related comorbidities. The field of anti-obesity medicine has recently experienced unprecedented results, but faces challenges in access as well as sustained results should the treatment be discontinued. Metabolic and bariatric surgery has a significant body of evidence that shows consistent and sustained results of 20 to 30% total body weight loss, even 5 years postoperatively. This equates to approximately 60% of excess body weight loss maintained over time. Excess body weight is the difference between a person's body weight at the onset of treatment and what that weight would be at a BMI of 25, or what is considered ideal body weight. This measure is also often used in payers' guidelines for bariatric surgery qualification. Evidence-based research goes back at least 20 years for metabolic and bariatric surgery and continues to show increased efficacy and significant impact on overall health outcomes, weight loss, and the combined disease burden of obesity. Surgery combines several mechanisms of action to achieve the associated result. It works like a diet in the sense that you cannot comfortably eat as much as you do with an unaltered stomach. We know that simply eating less, though, isn't enough. It also works like anti-obesity medications in that the body fundamentally changes the way it produces hormones and interacts with food. It does this not by adding something that can be stopped, by changing what it does. Lastly, in the bypass and duodenal switch, it changes how it absorbs food by not allowing the food to mix with digestive enzymes until lower in the digestive tract, resulting in fewer calories and nutrients being absorbed. Although the sleeve is a newer procedure, it is showing very strong results in weight loss and disease resolution. It is permanent, as approximately 80% of the stomach is removed, leaving approximately 20%, roughly the size of a banana, to hold food. It is a simpler procedure, as there is no rerouting of the intestines. It may not be a good option for those with acid reflux, though, as this condition may worsen after a sleeve procedure. This is because the pressure in the new stomach is much higher than that in the natural stomach. The bypass is considered the gold standard, as it has been practiced and refined the longest. It is technically reversible, as the 90% of the stomach that is detached from the pouch, which is roughly the size of an egg, remains in the body as a live organ with blood flow. It continues creating digestive enzymes that interact with consumed food lower in the digestive tract. It also offers very strong weight loss and disease resolution and may be more sustainable than with the sleeve. There's a greater chance of malnutrition than with the sleeve due to the absorption changes created by the revised digestive system. The duodenal switch procedures are most simply described as a combination of a sleeve and bypass. They afford the strongest outcomes with disease resolution, but also the highest risk of complications for malabsorption and malnutrition, so are often reserved for cases of very high BMIs or severe metabolic syndromes. As mentioned earlier, obesity is an invasive disease involving more than the BMI or the scale. As obesity worsens, it can impact nearly every aspect of a person's life and health. It manifests differently in each person, thus requiring a targeted, personalized approach to procedure selection and post-op monitoring. Some may present with cardiovascular compromise, manifesting in symptoms of hypertension, cholesterol, heart failure, and even stroke. The respiratory system can be impacted through the development of sleep apnea or worsening asthma. According to the American Heart Association, nearly half of those newly diagnosed with type 2 diabetes in the U.S. every year also have overweight or obesity. Both males and females with obesity are impacted by infertility, and rates of PCOS are also increased in this demographic. Liver disease, kidney disease, joint pain, the list goes on. Suffice it to say that health as a whole falls victim to the disease of obesity. As heavy as these statistics are, there is substantial evidence that demonstrates reduction of, or even resolution of these comorbid conditions following metabolic and bariatric surgery. Not only are established symptoms affected, but the risk of new onset development of these associated conditions is statistically decreased as obesity is appropriately and effectively treated. Sleep apnea is just one associated condition that can be completely resolved following surgical intervention for obesity. In relation to the microvascular complications of diabetes and nephropathy, there is even 20-year data showing the positive effects of metabolic and bariatric surgery. Long-term studies provide ample evidence that these comorbidity implications are not only impactful immediately following surgery, but over time. These results are not only supportive of the efficacy of metabolic and bariatric surgery, but also of the superiority and sustainability of this treatment option over other approaches. Continuing the theme of the health implications of obesity, did you know that the risk of developing certain cancers is in direct proportion to the incidence of obesity? There have been 13 cancer types identified to have increased prevalence in the population with obesity. This correlation continues to be studied, but there are several mechanisms tied to both. Both obesity and cancer manifest symptoms of hyperinsulinemia, elevated leptin, chronic inflammation, and altered hormone metabolism. Both also have ties to certain negative health behaviors like the consumption of high-fat, highly processed foods, which subsequently affect the inflammation previously mentioned. Studies show that as many as 40% of those newly diagnosed with cancer of any sort in the U.S. also have obesity, and that those with obesity also have a higher cancer-related mortality rate. Metabolic and bariatric surgery has proven to significantly reduce the development and mortality risk associated with cancer. Because this risk reduction can possibly attenuate over time from the surgical procedure, it's imperative that the interdisciplinary team be actively utilized during the program process and follow-up protocols to adequately impart that surgery is a tool, a treatment, and that it must be intentionally and consistently used to produce sustainable change in health behaviors that may affect cancer risk. The increase of mortality risk associated with obesity does not end with cancer. All-cause mortality is increased by as much as 5% in the population with obesity, but that risk is directly impacted by the results of metabolic and bariatric surgery. In fact, studies have shown a decrease of 30 to 40% in all-cause mortality. The impact of this decreased risk even shows to increase year over year following the surgical intervention. As mentioned, quality of life is significantly impacted by obesity, and studies show as many as 95% of post-operative participants in a qualitative study reported an improvement in contributing factors. With outcomes showing an increased life expectancy of greater than 6 years, how amazing that those years are full of quality and improved health. When considering obesity and its evidence-based treatment options, it's imperative to remember that obesity is chronic. It's a relapsing and multifactorial disease process. Whichever treatment option is chosen, the expectation should be that obesity will require consistent and ongoing therapy to achieve sustained results. Additionally, Due to the multifactorial causative factors related to the development of obesity, the individual must be considered throughout the development and implementation of the treatment plan. There is no one-size-fits-all approach that can be applied to obesity treatment, and to assume such would be a disservice to our patients. We know that metabolic and bariatric surgery shows the most sustained, studied, durable, long-term efficacy in obesity treatment. But we also know that it is not an easy button. Intentional, ongoing lifestyle modification prescribed by and in collaboration with the interdisciplinary team and patient best positions that patient for sustained results. Surgical intervention is the pivotal piece around which the lifelong treatment is modeled. Despite a targeted treatment plan, there will be times following the primary metabolic and bariatric procedure that additional treatment must be considered. There has been a significant increase in recent years of patients seeking out revisional metabolic and bariatric surgery options. The need to continue viewing the patient as an individual does not end following the selection of that initial procedure, and revisions are not the only option to address these patients' concerns. The thorough surgeon will reevaluate the patient and listen to their concerns and goals, perform additional studies or tests, and engage the interdisciplinary team to develop the best treatment plan for each patient. Factors leading to the consideration of a revisional procedure or adjuvant therapy include weight regain after acceptable weight loss, insufficient initial weight loss despite appropriate lifestyle modifications following a surgical intervention, and is insufficient resolution in the obesity-related comorbid conditions, or management of post-operative complications such as malnutrition. It is critical that the surgeon and team work closely with this patient to carefully select the most appropriate next steps. The rationale behind seeking revisional or escalated obesity treatment varies from person to person, and treatment options are available to best serve each individual need. If the surgeon determines that an additional procedure is both necessary and appropriate, they must then determine, much like when selecting the initial procedure, which is the right choice for that individual patient. Sometimes a revision is needed. In this case, the efficacy of the initial procedure can be enhanced by altering what was already done. An anastomosis, sleeve, or pouch could be reduced, or limb distalization could be performed to augment results. In other cases, the initial procedure could be converted to a completely new one, whether by predetermination or to address unexpected outcomes. Occasionally, the initial plan is a two-stage procedure that involves an anticipated conversion after a prescribed amount of time or weight loss has been achieved. A sleeve, for instance, could be converted to a bypass or a duodenal switch to escalate therapy for patients who have not achieved their desired results of weight loss or comorbidity resolution. The last anatomical alteration of note in these guidelines is a reversal. Although this is not an option for patients who initially underwent a sleeve, as there is no remnant stomach to reattach, it is an option to address concerns resulting from other procedures. The sleeve is a permanent procedure. Should a patient with a gastric bypass or a duodenal switch require a reversal due to malnutrition or other health anomaly, the anatomy may be reversed to address these concerns. While this is not a common occurrence, it is an option for these patients. Finally, the field of anti-obesity medication has experienced unprecedented exponential growth in recent years. Evolving research shows exciting efficacy of adding an anti-obesity medication to the therapeutic regimen of postoperative patients seeking to restart or accelerate weight loss and comorbidity resolution. This adjuvant therapy may help patients reach their goals without the need for a revisional procedure. In conclusion, metabolic and bariatric surgery has an extensive body of data-rich evidence supporting the assertion that it is the most effective, most sustainable treatment yet available in the battle against obesity and its related comorbidities. As defined by the American Medical Association in 2013, obesity is a chronic disease process. It affects nearly every aspect of a person's physical, mental, and social health. The human body is adaptive, requiring continued and intentional use of treatment options addressing obesity to be successful. But when that patient is empowered and determined to assume control over their behaviors, when they effectively collaborate with their interdisciplinary team, the treatment of metabolic and bariatric surgery consistently produces significant and sustainable results. These results affect weight loss, comorbidity resolution, and mortality risk in this demographic.
Thanks for the organizers for including me today in this presentation. And I'm excited to talk about a topic that I'm most passionate about, and that is insurance and patient access. For those of you who don't know me, I'm Joe Nadglowski. I'm president and CEO of the Obesity Action Coalition. I'm an employee of OAC. I have no personal relationships with industry, and just about every member of the evidence-based obesity care industry supports OAC. A little bit about my organization. We are the patient advocacy organization in the obesity space, a charity formed in 2005, dedicated to educating and advocating on behalf of those living with obesity. We currently have about 85,000 members throughout the US. Of course, that seems like a lot of folks, but the reality is there's more than 100 million people living with obesity in the US, and so we definitely need to grow our numbers. And our mission is to elevate and empower those affected by obesity through education, advocacy, and support. We were created in 2005 with ASMBS's help, and in fact, it was after a meeting on bariatric surgery when a legislator questioned the lack of patient advocacy around obesity care, and specifically bariatric surgery. He stood up that meeting and he said, you know what? I'm asked every single day to do something about the obesity epidemic. But it's always by a public health official or by a doctor. I've actually never had someone with obesity walk into my office and ask me for help. And then he went even further. He said, you know, I could pass a law in my home state today making bariatric surgery illegal, and not a single person who needed it would march on my front steps. And so we created OAC to do that, to make sure there was an organization that would march on someone's front steps if they were harming people with obesity. And we're proud of the work that we've accomplished to date, giving a voice to people living with obesity. If you are a member of ASMBS, you are a member of OAC. ASMBS pays your dues in OAC, but you may not regularly be receiving our emails because of privacy reasons. Sometimes ASMBS can't give us your email address. So please email info@obesityaction.org to make sure we have your email address if you're not regularly receiving emails from OAC. Should be getting a couple a month from us. And if you're not getting them, reach out to us because we'd love to make sure you're staying up to date on our latest information. OAC's membership is 90% patients. The other 10% are made up of healthcare professionals and others, but we need your help in growing our membership. So please make sure you are encouraging your patients to join OAC. There's no reason why someone can't join OAC. We have free membership categories as well as paid membership categories. So financial reasons should not be a reason for not joining. So please encourage your members to join. And if you're ready to take the next step and your hospital or practice really wants to encourage participation, we do have programs where you can actually buy memberships in OAC for your patients. This is called our sponsored member program. And if you're interested in that, Lisa Gresko-White's contact information is on the screen. We have about 50 ASMBS member hospital programs across the country participating in this, and we'd love to have more. One of the things that we do at OAC, in addition to our education and support of people with obesity, is we teach people how to be an advocate. And so I'm going to talk about issues we can advocate around today, but we can't just talk about them. People actually have to take action on them. And if you've ever wanted to educate yourself on how to be a more effective advocate, we have this great 8-part video series, the details here on the screen. And I would encourage all of you to take a look at this and encourage your patients to take a look at it as well. And then after you've viewed that and you're ready to learn even more, we see as a team of folks led by Crystal Jones at our office, who can actually take you through an advocacy 202 process, teach you the next steps in advocacy. Crystal's contact information is here. And if you're interested in learning more about how to be an effective advocate, please reach out to Crystal. It really does take more than talk to change the world. It takes a committed group of trained and dedicated advocates. And that's really one of our goals, right, is to increase the number of people who know how to advocate on behalf of the issues around obesity care. So let's talk about care for people with obesity and what we know. So what are the realities of seeking obesity care? Who seeks that care, right? So individuals seeking obesity care and comprehensive care is relatively rare. Most estimates are less than 10% of people eligible seek such care, but many publicly don't share seeking such care because of the stigma around obesity, which is a topic for another day. Obviously, societal pressures, bias, and a lack of understanding contribute to this. And this is made at times more complicated by a healthcare system that seems to spend more time stigmatizing people with obesity than trying to improve their health. We also live in a world where there are, especially now with this compounding of GLP-1s, where you see these short-term fixes, snake oils, and other non-evidence-based therapies being promoted to people with obesity. And I really do have significant worries around the snake oil, and especially this issue around compounding as of late, because we really do believe that these are going to cause patients to continue to weight cycle or face worsening weight or health issues. So the reality is that comprehensive obesity care utilization is particularly modest. And I think you know this, right? We know from the surgery data only about 1% of people who are eligible for metabolic and bariatric surgery seek it. There are reasons that are because of coverage, which we'll talk more about in a minute, but there are also some of these bigger societal issues at play. And so we need to, as we talk about comprehensive care for obesity, we need to remind our employers and our insurers who are paying for this that this is not 42% of the population who's going to be seeking this care. It is only a portion of people who are ready to seek such care. Here's that actually data broken down about the 10% of people seeking help from medical professionals. And you can see here that, you know, about half of people go self-help when it comes to trying to address their obesity. And 30% do nothing. These are the folks I say they've given up. And then you see a few percent, about 10% go to some kind of healthcare professional, but only 4% of them seek care from a doctor. And so the thing that stands out to me about this graph as well is, you know, we see a lot of surveys out there, a lot of suggestions that people with obesity don't know they have obesity. And actually, this proves that's not true, right? You only have a small percentage of the population here who hasn't tried something or denies that they are overweight. And so I think we need to spend more time trying to influence the people who have given up or people who are going the self-help route, that, you know, medical care is appropriate for their treatment of their obesity, and it's okay to seek that help. You know, there's a stigma around living with obesity, but there's also a stigma about asking for help for your obesity as well. Now, you know, once someone's decided they're ready to seek care, then access to comprehensive obesity care is often limited. As all of you know, obesity screening and counseling is required to be covered under the Affordable Care Act. But the harsh reality is that we see insurance companies abusing this requirement all the time, oftentimes limiting coverage to one visit. I even saw one Medicaid plan that limited people to half a visit per year for their obesity. And we still see these blanket exclusions. In fact, exclusions like this used to exist in my policy here in Florida, where no matter what, there's a statement that says we exclude anything to do with obesity, even though they're required in many cases, you know, to cover counseling, and in some states to cover bariatric surgery. They still have these statements, and these statements are abused by insurance companies. Oftentimes we have conflicting statements where one day the insurance companies say, well, no, we'll cover your bariatric surgery because that's in a separate statement. And other days they'll say, well, we have this exclusion, so we're not covering it, even though we have another statement that says we cover it. And this is the harsh reality. And this is a real example of one of those exclusions that came from a state of Louisiana plan. And then the other thing is we find that coverage is often hidden and or difficult to decipher. Again, there's this irrational fear by many insurers and employers that they're going to get overwhelmed by people seeking obesity care. And so they make it hard to find the care. They make it kind of fuzzy, you know, and one of the things I encourage a lot of employers and insurers to do is to stop doing that, right? Create an actual list of what obesity services that you offer, because we realize that not all of these services are going to be in their traditional health plan. Some may be in their employee assistance program, or they may be in their wellness program. And it's important that your members and or your employees know where such services are. It's time to stop hiding such care. It's time to stop making people earn such care and make it freely available, because we really miss an opportunity if someone woke up this morning and said, today's the day I want to do something about my obesity, but then we put barriers in front of them. Then we move them back into that category that's, is not doing anything, is not interested right now because they've given up on seeking help. So now we move forward again, talking more about, okay, I've decided I want care. I find I have some coverage for care, and then patients are made to jump through the hoops and the hurdles that many of you probably live on a daily basis. We see patients are required to participate in one last diet or non-pharmaceutical, non-surgical treatment before being able to access treatments behind behavior change. This was quite frequent with bariatric surgery coverage. With these 6-month waits. Now, through some great work of ASMBS and others, we've started to see these reduce, but curiously, they're popping back up again. So people who are seeking medication coverage now are oftentimes required to go through a 6-month diet before they can access medications. We see these very frustrating pre-authorization processes. Probably don't have to talk to this group very much about this. The frustration, the inconsistency that often happens here. We see lifetime limits on treatment, 1 surgery per lifetime. One of the things the Affordable Care Act was supposed to do was eliminate financial caps for services. You're not allowed to say you can't only spend $1 million in a lifetime anymore. But what insurance companies, how they balance that or reacted to that is to create these other caps, like 1 surgery per lifetime, that we see pretty frequently with bariatric surgery. We don't see this with knee replacements, hip replacements, cardiovascular procedures. So another way that obesity care is treated differently by insurance companies. We see specific comorbidity requirements. You must be on 3 medicines for hypertension before hypertension counts as a comorbidity for obesity. We see the caps on the number of visits, which I mentioned earlier about dietitians. And we see these higher than usual copays or deductibles. Another thing that we actually think is illegal or improper under the Affordable Care Act, which requires that we not discriminate based on health conditions. And in fact, ASMBS and OEC, have asked the past 3 administrations to enforce this rule around bariatric surgery, but it's pretty common for us to see higher deductibles than we see for any other procedures for bariatric surgery. Let's take a quick look at the snapshot of what coverage looks like today. So hopefully all of you have seen this map before. This is from the ASMBS's toolkit. This is obesity coverage under the Affordable Care Act. And basically any state that is not red requires that bariatric surgery coverage be included in the exchange plans, which means they're plans that are sold to individuals or small businesses. States in red have no such requirement. And by the way, if we were going to overlay a map around obesity over this, we would see states that are red have the highest rates of obesity. So there is still work to be done here. And we'll talk later about one effort we're currently undergoing in Minnesota to actually change the essential benefit plan in Minnesota to be the first state since 2017 that has added an obesity service to their essential benefits. This is our bariatric surgery map. We're down to 3 states with outright exclusions. That's Idaho, Montana, and South Carolina. We'll talk more about South Carolina in a few minutes because we already have advocacy efforts going on there. But a number of other states do have other restrictions and or pilots. For example, Louisiana is currently operating under a pilot. In Pennsylvania, you have to have diabetes to be able to access bariatric surgery. So coverage isn't perfect in all these cases, and there's still opportunity for advocacy in many of these places to try to improve care. So if you have a large patient population that is state employees, I would really encourage you to look at advocacy around state employee coverage because it's one of the areas we can have the most influence on. Here's our Medicaid coverage. We have 2 states that currently exclude bariatric surgery under Medicaid. The rest do cover it. Reimbursement is a very big problem here, though. In many states, the reimbursement is so low, it's in effect an exclusion of bariatric surgery because hospitals don't want to take these cases. So there is opportunity there, again, for you or for your state chapters to think about, can we interact with the state Medicaid department to improve reimbursement and make sure that more people under Medicaid have access to bariatric surgery. I include some data around anti-obesity medicine coverage because this has become super a hot topic as of late. And so what we see is an ever-moving target with states adding and subtracting benefits regularly. That's why I did not put a map up, because by the time you see this presentation, it'll be out of date already. Some states are adding benefits, but are doing so with really strict restrictions. For example, Connecticut, which added the benefit in 2023, requires you to see their preferred telemedicine provider and start with a non-GLP-1 drug. Now, we can think about this as a positive, right? They added coverage. It's not great for everyone, though, because say, for example, in your bariatric surgery practice, if you wanted to provide this medicine for one of your patients, you have to send them to a telemedicine provider. You can't do so directly. But maybe that's better than them having no coverage at all. So the reality is it's probably a good thing that we've seen some coverage start, but there's work that needs to continue to make sure that everyone ultimately has the ability to prescribe these medicines. A lot of the fear around medicines is this irrational fear that, unlike bariatric surgery, which only has a 1% utilization, that 50% of the population is going to use anti-obesity medicines. Well, first of all, that's not possible from a supply standpoint because there just isn't that much drug available, and supply shortages are pretty normal. But it's also not reflective of what the evidence shows us around people seeking obesity care. I would be surprised if people seeking AOM therapy, is even into the double digits, going above 10% of people who are eligible because of the stigma around seeking help for your obesity. We see really concerning fights around cost around this, and most of the conversations around AOMs are around costs. And North Carolina recently engaged in a very high-profile battle over their AOM coverage for state employees, and has told their state employees starting in 2024, unless you're already on one of these drugs from the year prior, we're not going to allow you to access the new GLP-1s. The North Carolina treasurer has been very public, calling out the manufacturer of these medicines, Novo Nordisk in particular, over the prices, demanding that they receive prices similar to what's paid in Europe. It is interesting. It's been interesting to watch the back and forth around this because there are three parties involved here. It is the drug company, it is the state, and it is what is known as a pharmacy benefit manager who is negotiating rebates on behalf of the state, but does keep a portion of those rebates. And so the question becomes, is this a problem between North Carolina and the drug manufacturer, or is this a problem between North Carolina and their pharmacy benefit manager who is not giving them enough of the rebate back? We'll wait to see. There's actually a hearing about this coming up in a couple of days. Unsurprisingly, our friends in the pharmaceutical industry really want to seek state employee coverage, so it is a high priority, and you see a lot of activities. I'll show you a map later of activities that we're engaged in, but there are a number of states where state employee coverage is a high priority, and the AOM companies are pushing very, very hard. Medicaid coverage is also pretty intermittent with regular changes as well. So again, no map because I wouldn't feel confident the next day that the map is still accurate. We have seen a handful of states approve coverage, but yet to put those AOMs on their formularies. So we talked about Connecticut earlier for state employees. They also added Medicaid coverage, and they did so now, 7 months ago, but still no action yet. And so people still don't have access to those medicines. So work's still to be done there. Some states only cover for teens, and worth acknowledging that. You remember, Medicaid was typically set up in many states as the primary participants in Medicaid are children and or pregnant women. And so therefore, some states really limit their care to children when it comes to obesity care. And of course, the same barriers we probably see in other places around costs and utilization is the primary barrier. But I do find the cost discussion pretty surprising because Medicaid always gets the best price by law, meaning they get the highest rebates. And the federal government often pays a large percentage of the cost of Medicaid plans. This can be anywhere from 50 to 90% of the money comes from the federal government. So most states are actually paying pennies on the dollar for these AOMs. And so this debate around cost is somewhat surprising for me when it comes to Medicaid. Surprisingly, our friends in the pharmaceutical industry are supporting Medicaid coverage. And this is unlike in other health conditions. Most pharmaceutical companies really avoid Medicaid as much as they can because they are required to give such high rebates. And in fact, in some cases, they lose money on the medicines because of the rebates that they're required to sell. So I'm often a critic of our pharmaceutical industry friends when it comes to their behavior around these medicines, especially around price. But I do have to acknowledge that they are supporting access and equity by supporting coverage for Medicaid recipients. We will hope to have more data around Medicaid coverage specifically for AOMs here in a couple months. We've just purchased a new data set. And by the way, that data set will include more than just information about medicines. It'll actually include information about a surgery and surgery requirements for many Medicaid programs and the Medicaid managed care programs that many states have. So look for that data later this year. I want to take a break for a second and just share this headline that I saw just recently, because it's been sticking in my craw a little bit here, where it says the Ozempic effect ensures ease access to bariatric surgery. And I will say, I'm not so sure this is exactly true. I think it is likely way too soon to tell. We have seen some intermittent reductions of barriers to bariatric surgery, but I think that's more likely because of the work that ASMBS, OEC, and others have done, trying to tackle those barriers more than just the medications. I think solid data around medication use is hard to come by with supply chain issues, changing insurance rules. But when you look at the data that we do have so far, it doesn't appear people stay on these medicines long term, meaning an argument that medicines are going to cost more money than surgery isn't necessarily going to be true in the short term for insurance companies. So I would be very, very cautious with arguments like that, and make sure that we acknowledge what's probably really driving some of these changes, which is our advocacy work more than the medications themselves. We'll have to wait and see. I could be proven wrong around this, but my belief is that insurers would rather not pay for any obesity services at all. I don't think they're going to say, we're going to make getting surgery easier because we don't want to pay for meds, is something that's in their thought process. Again, I could be proven wrong, but we'll have to wait and see what time tells us and when we have better data moving forward. So let's talk about our specific advocacy efforts to try to improve those maps that I've shown you earlier. I want to talk briefly about federal advocacy. This continues to be primarily focused on the Treat and Reduce Obesity Act. You're probably tired of me talking about this if you've heard me speak before. We've been working on TROA now for almost 12 years. It would expand who can counsel for obesity and cover and allow medications to be covered for Medicare recipients. And when I think about this from a metabolic and bariatric surgery stream, it definitely opens up new revenue streams for surgical practices, allowing counseling to be covered. Of course, the major policy barrier is primarily focused on costs. I think we have convinced most legislators that obesity is a disease and it needs to be treated. What we haven't convinced them is how much money they're willing to invest in this to fix the problem, right, kind of thing. And so, and a lot of these headlines and the hype around the new GLP-1 based AOMs is kind of hurting our effort here, because people get focused on the price and the wrong people using the medicines instead of actually on the health benefits and the right people using the medicines. We'll also continue to work with some of the different federal agencies, the Office of Personnel Management, which oversees the Federal Employee Health Plan, which has one of the most comprehensive benefits for obesity care. And we always monitor the Centers for Medicare and Medicaid Services, which is who oversees Medicare, because they have a national coverage around bariatric surgery, national coverage decision. And, there's always the possibility that would be reopened, and we would need to advocate around changes. We don't have any signs of that right now, but we continue to monitor it, and we'll actually be meeting with CMS shortly. So hopefully have a better feel for their plans in the next couple of months. Here's our state advocacy map. And as you can see, this is a busy map. So in any state that is any color other than gray, we have active advocacy efforts going on. I will be honest with you, this is tough for OEC. We are an 11-person, staff person organization, although we have thousands and thousands of volunteers. And maintaining legislative activity in so many states is hard for us. So if you are interested in getting involved, you see your state with listed in any of the colors here, and you want to participate in that state, let us know, because we definitely need the support and we could use it. And I'll cover some examples of the kind of advocacy we're doing, but just know that most of it, as I mentioned earlier, is state employee, Medicaid coverage, or in some states where we try to go for comprehensive care, meaning we're going to try to force all insurance to cover obesity services. So, those efforts are in full swing right now. Most state legislators meet the first few months to half of the year. And so we are super, super busy right now. OAC has identified 5 priority states that you see listed here: California, Florida, Minnesota, Pennsylvania, and Tennessee. Although, as you can see on the previous screen, we are pursuing activities in many, many states. Much of this work, I think, if we looked at this last year, there wouldn't quite have been 35 states, maybe 15 or 20. And so I do think the new medicines have driven more interest politically around these issues. And so that is good. But please note that when OEC pushes forward activities, it's not for one specific treatment. So if you look at our work in many of these states, it's going to be for comprehensive care, meaning we cover counseling, meaning we cover medicines, meaning we cover surgery. So we want the full range of obesity care. We urge caution around bills that only focus on one aspect of this, because that makes the different groups in the space, fight among themselves. And I will be honest, I think ASMBS for years with Dr. Blackstone, Dr. Morton, and others have really championed, more than a decade ago, this idea that we need to advocate for all care, and that's been OEC's position for that length of time as well. Another new development in the last 12 months has been the American Diabetes Association has become very active at the state level, helping us pursue these legislative issues. They have a huge infrastructure and great advocacy resources. So we're excited about their work, and we're excited that they are championing access to obesity care. And worth noting that on the industry side, Novo Nordisk is particularly active in state advocacy. You might be contacted by one of their reps as they're working on that. Lilly is gearing up with their approval in the last few months. But we would definitely benefit from more activity by the bariatric surgery industry. Their efforts have not been as forthcoming as they've been in years past. And so it'd be nice to see the major players re-enter on the advocacy side, especially at the state level. So I wanted to highlight a couple of ways we are trying to tackle these barriers and trying to make change to the system. So one is in Minnesota around essential benefit. Many of you remember that map I showed earlier. This is based on the Affordable Care Act. Essential benefits are the minimum services that are required for the individual or small business market. Only one state, Colorado, has ever changed their essential benefit plan to add metabolic or bariatric surgery, and this was in 2017 with a concerted effort by OEC, ASMBS, and Medtronic, and it was great work. We are leading an effort in Minnesota right now to try to have obesity services declared essential. We've identified several champions, and our ultimate goal is to model what we do in Minnesota and roll it out to future states in 2025. And one of the reasons we're doing this, and it's both this around essential benefits and with mandates that I'll talk about later, is there is some belief that a new federal regulation does make it easier to expand essential services without the state bearing substantial costs. And so it might be a unique opportunity. I will say that tackling essential benefits is likely only for states where they are willing to talk about the Affordable Care Act or Obamacare. As you know, some states refuse to participate in that, and the feds control those activities. And so therefore, this tactic of attacking essential benefits isn't going to work in every state, but we'll talk about the other tactic, mandate, which may be more applicable in those states that are not engaging in the Affordable Care Act, Obamacare, for political reasons. We're also trying to ramp up our work in South Carolina around state employees. State employee coverage, definitely what state employees have covered definitely influences the other large employers in the state. As most states, the state is the largest employer in the state, and they're competing with the other major businesses. South Carolina is one of only 3 states that doesn't cover bariatric surgery for their state employees. And I want to applaud John Scott, who's taken the lead for both ASMBS and OEC on having conversations around this. They're taking advantage of the buzz around the new anti-obesity medicines to get the state to consider comprehensive obesity care again. And so we're hopeful for a meeting here in mid-year this year to develop a plan around obesity care that might roll out in 2025 for state employees. Long way to go, but there's still but a great opportunity. And we've learned a lot from South Carolina. We have to be patient. This takes time, right? You have to use your hospital resources, take advantage of those lobbyists, be open to partnering. So pharma and surgery working together has partially reopened the door there in South Carolina, and always be looking for new legislative champions. Again, people are elected to their positions are new, and you need to go visit them and say, hey, look, you guys haven't done this for a long time. This is important. Are you willing to champion this issue? And we found new champions in South Carolina. So the process always continues. It's always important that we continue the work, try to educate our elected officials. Colorado, we are working with the American Diabetes Association to mandate obesity care coverage, including metabolic and bariatric surgery. There's only one other state, or a few other states actually, but the one most notable state is New Hampshire that actually has such a mandate. Keep in mind that large employers, again, folks who are self-insured, do not have to follow state mandates. So that's one exception to this rule. But we are partnering with the American Diabetes Association to mandate coverage in Colorado. And it would not only apply to businesses and individual market plans, small businesses and individual market plans, but also other state regulated plans like the managed Medicaid programs, et cetera. Mandates are a heavy lift, and insurance companies always oppose these full force, but I think a lot of the conversations around obesity have really created a kind of a seed change when it comes to the public, and they're getting tired of the fact that obesity services aren't covered benefits. So it'll be interesting to see how this progresses this year. It's also be interesting to test the power of our friends at the American Diabetes Association in supporting this effort. So we'll see what happens, but it's another good example, and we'll have good data after this year to know if we can move a mandate forward and what barriers we face. More tackling barriers, other recommendations that I would have that are not directly trying to get laws or rules passed in your state is to make sure you're filing those appeals. I know they can be frustrating. I know peer-to-peers lately don't seem like you're making much progress with them, but there are new rules that are going to make data on prior authorization denials public starting in 2027. So we need to make sure that we are appealing frequently so that we can actually show that data and see that data and when the data is released publicly. I would encourage all of you to introduce yourself to your legislators at the state and federal level. Offer yourself as a resource, and Chris Gallagher, who is OEC's and ASMBS's lobbyist, can help you with this, and his contact information is on the slide. I would encourage you to make sure you know your hospital's lobbyist. Your hospital has a lobbyist. They may have a firm, or they might have someone on staff, but they are often really well connected and can help you get metabolic and bariatric surgery on your hospital's priority list. And that's definitely something you should try to do. And they can help you in many cases. You may not have to use Chris to meet your legislators because your hospital lobbyist can do so for you. And then I would also encourage you to make sure you try to form a relationship with your Department of Insurance or your insurance commissioner. I know it's hard. Some of these departments are in effect do little to nothing, but others are super active. And so I would continue to engage with them, and maybe you can find someone on those teams. So you ran into a barrier, an exclusion, you had a prior authorization denied, write a letter to your insurance commissioner, share it with them, see what they'll do. We need to keep the buzz up. And remember, these departments oftentimes publicly publish areas that they are hearing about frequently. And it would be nice to see, hey, insurers are giving people a hard time accessing metabolic and bariatric surgery on those lists. So I would encourage you to do that. I also would encourage you, and this is what OEC is about, is getting your patients involved. I think we miss a lot of opportunities when we tell patients they don't have coverage for metabolic and bariatric surgery. Oftentimes we just send them off. You need to keep a list. You need to make sure you have the ability to reach out to them when you're contacted by a policymaker, the media, et cetera, someone who might want to talk to a patient denied care. And frustrated folks really make the best advocates, so encourage them to join OEC to learn how to advocate for themselves. We are not going to immediately be able to find them care, right? This is going to take them engaging in some work and some advocacy, but it's time. They need to realize that they can join the fight, and it's more likely that they'll be able to access coverage in the future if they join the fight now. And if you ever interact with a legislator, a policymaker, or a key official, include a patient or two, ideally someone who is seeking care and someone who has benefited. Let's just not bring out all our superstar patients. They're great, and I love to have them and see their successes. But we need to remind policymakers the other side of this as well, people who are still seeking care and haven't found it yet. So I'll leave you with a few final tips. You need to get involved, right, when it comes to access to care. Complaining about access but not getting involved in solving the problem just simply isn't enough. I know a lot of people like to complain, but the only way we're going to change this system is if we get involved. So you can't expect someone else to solve this issue for you. So please, even if it's small steps, doing those appeals, encouraging your patients to get involved with OAC, start, right? We need folks involved. We have to be patient. It really does take a long time. We have to build relationships, and keep in mind that it's not worth flaming or screaming at someone or burning a bridge with someone because they don't deliver what you want them to deliver. You never know if the next year they're going to be one of your biggest supporters. So please be helpful and be constructive. Let's not attack our policymakers who are making these decisions, even if you think they are the wrong decisions. Be brief but powerful. This is really hard for me. I love to talk, as you can tell, but I would really encourage you to think about brevity. Say it in 5 minutes or on one page. When policymakers are extremely busy facing numerous issues. I learned this lesson early on. I happened to walk on an elevator in Washington, D.C., and a very famous senator walked on the elevator with me. And I had that 3 to 5 minutes in the elevator, and I hadn't practiced my elevator pitch, my little 5 minutes saying here, and I missed my opportunity to do that. So practice. It takes a little bit of time to be brief. And by the way, if I had done a good job and he said, well, let Joe walk with me and you can ask me more questions, that's fine, right? But we got to work to be about being as concise as possible. And I really would encourage you to encourage people to have confidence in the process and that their voices really matter. Voters are powerful. Sharing your story is powerful. Government media is organized to serve the public. So please, please encourage your patients to get involved. And I encourage you to get involved as well. So I'll leave you with a final thank you to ASMBS and especially the Access to Care Committee that I've had the privilege of working with now for almost 19 years. Together, we've accomplished some remarkable things. We've improved the lives and health of people. There's more work to be done, and I would encourage you to get involved today so we can continue to improve access to the treatments of obesity. Thank you very much.
Whoops, sorry. Just trying to get us back on track here. Can everybody who presented show themselves? I do want to open this up for questions that anybody may have. I already have a question, both for Dr. Kothari and Joe. And I don't, Joe, I appreciate sharing all that information. You've done a lot of work. Let me just quickly backtrack and thank everybody for their presentations. Fantastic. What a great job. And I really appreciate this. My question to you both is, do we know how many insurance companies have grasped onto these new guidelines, if any, and how can we go about fighting that? I know you've got your own work that you're doing, and I don't mean to add it on to you, but what can we do to push these through?
Yeah, I think it's a good question, and we do. And I think Dr. Kothari mentioned that in his opening remarks. We've seen a handful of insurers starting to adopt these, and it is oftentimes an individual surgical practice, someone from the team who reaches out and says, you know what, I see that you're going to update your guidelines. Many of these companies have like an annual or every 2 years process of their guidelines, and they say, here are the new ASMBS IFSO rules, and will you consider updating them? And medical directors often do that. And in fact, I think in 5 states right now, and I'm sure our friends on the Access to Care Committee can share this, there are public comment periods are available right now from a bunch of Blue Cross plans that are actually considering, adopting most of the new guidelines. So I think there's lots of opportunities there. You have to start with asking, right, kind of thing. And again, the other question becomes too, is if you have a patient that meets the new guidelines but doesn't meet an insurer's existing guidelines, then you have to be willing to go through that appeals process, right? Don't take no right away, right? You go through and you give them those. Here are the new guidelines, right? Your policy is violating the guidelines, and go through that process. Is it immediately going to guarantee that patient gets coverage? It's probably a small chance in certain times, but we have to. The more and more of those appeals that get done, the more likely those policies get changed. I worry sometimes we're not as noisy as we used to be about getting access to bariatrics. So we kind of got in our routines. We tell too many people no, we don't fight as often as possible. So I really encourage people to fight as hard as they can and use these new guidelines. They're so wonderfully well written. It's all documented. Say, hey, justify to me why you're not following the guidelines.
Dr.
I would echo what Joe said. And Joe, I just want to congratulate you on a great end note, as well as to all the other speakers and the privilege to have shared as well. I recently just had an example of what Joe just said. I mean, I had a denial. I set up a peer-to-peer. The reviewer was quoting the 1991 guidelines. I didn't say I was an author. I didn't want to play the author card, but I just said, "Are you aware that the ASMBS has updated guidelines?" And she goes, "Well, we look at our policies once a year." And I told her that I would encourage her to look at these guidelines and embrace them if possible. And she ended the conversation with the denial. And I was, of course, very frustrated by that. But I've never had this happen before, where she called 14 minutes later and said, "We looked at the guidelines, and you're right." She goes, "There are updated guidelines, and we have adopted them, and this patient is now approved." So that was really great to see, just a local win myself personally for all the work that ASMBS, OSC, and others have done as well.
Yeah, thank you. And what can we as providers do, or even as organizations do, to encourage these new guidelines that we have? I think there's a recommendation, and correct me if I'm wrong, but when we're doing any research and using those new guidelines rather than the old, I think is something that's been encouraged for us to do. Did I hear something wrong, or is that?
Say that again, Karen.
My question is, what can we do as providers, maybe as researchers, to encourage the use of these new guidelines? Is that something that we're doing at a bigger level to use, again, those new guidelines in our new research and avoid the old guidelines?
Yeah, no, that's a fair question. The question is, a lot of us have been reactive, and on peer-to-peers. The question is, can we be proactive? I mean, should we be distributing these guidelines and like I said, the fact sheet that shows the key takeaways and the changes from the old to the newer ones, and just submit them to the insurance commissioners of every state plan and things of that nature, and every plan that you can deal with, whether those are the Aetnas, the Blues, the Cignas, et cetera, and things of that nature. I think that's something that between our Access to Care Committee and our Insurance Committee, I think that's a good next step. Like, should we just be more aggressively proactive at submitting these, making sure that they're coming across on their email or in a snail mail form, that they have these available, and at least, like I said, if these policies get reviewed annually, at least that they're aware of them.
Thank you. And Joe, I think you already alluded to, and actually was very succinct in your presentation, that for us to get involved at a local level, even, that we could contact OAC to get any further information to help us, even with insurance companies, even with our state, at the state level, to do anything along those lines. Correct?
Yeah, absolutely. And if you understand, especially if you see something, I mean, remember, we're trying to monitor all these things. It's our members that feed us in this information that something's going on in the state. Like just today, I learned from one of my members, there was a bill introduced in New Jersey to make it illegal to discriminate against people with obesity. It's perfectly legal in this country to, except in Michigan and in Washington State, to outright discriminate against someone who has obesity. Well, in New Jersey, they introduced this law. I didn't know about that, right? It's our members who see that. So if you see something like that, if you're running into a specific issue, if you hear your city or your county or your state is doing something, reach out to us, because we have, through our membership and our what we call our Legislative Action Center, we have an ability, for example, for us to create a tool where you could encourage your patients to write in about this issue. You could just refer them to this page, and it's a tool that would automatically send their emails or their letters on their behalf, and we're happy to do that. We have a number of those going on right now. As I said, it's a little crazy right now because it's the beginning of legislative session in many states, but look for a lot of those coming forward. And one just comment, because when I recorded that yesterday or the day before yesterday and then between today, so state of North Carolina did in fact end their state employee benefit for anti-obesity medicines. And so for many of you who know the space, North Carolina has always been kind of in the forefront of obesity care, right? They were first to adopt bariatric surgery. They were first to adopt counseling, and they were the first to adopt these AOMs, but they're in a huge fight with the both their pharmacy benefit manager and the pharma companies themselves about trying to get better pricing. And but what they're going to do is they're going to harm their patients by doing that. Like this is a decision, it's frankly, it frustrates me where the insurer, the pharmacy benefit manager, and the pharma company all need to get in the room and work it out, because you are harming people's health and lives, right? By suddenly, giving them hope for the last, 16, 18 months and then suddenly taking it away. It's a frustration that, we've seen over and over in bariatric surgery. Luckily, we haven't seen it as frequently lately about removing coverage, but it's a reality there. So you have to definitely get involved. And if you see an issue, don't be hesitant to just, you can get all those emails in there, info@obesityaction.org. You can write to me personally, whatever it may be. If you see an issue in your state, make sure you just tickle us about it, just to make sure we know about it.
Thank you. There was a question earlier in regards to pediatrics and adolescents, and I will tell you this much, that this presentation earlier today by myself was aimed at just sharing what the new recommendations and indications were from ASMBS and IFSO. There are some guidelines ASMBS has put out in 2018 in regards to pediatrics and adolescent programs, as well as AAP has guidelines, and also anybody who has an MBSA QIP program, there are standards in regards to that as well for pediatrics, specifically with staffing, to have a pediatric medical advisor and behavioral health specialist. Regarding the elderly or older population, because I'm starting to get close to that and don't want to be called elderly just yet, they don't have any specific guidelines per se for us just yet. I don't know if that's something that we'll ever tackle at ASMBS. But I will say MBSA QIP does have limitations when it comes to the low acuity centers, and they limit the age of operating on patients for metabolic and bariatric surgery to less than 65 and greater than 18. So I just wanted to share that information if anybody else had any questions regarding that. Other questions, other comments from our panelists as well? No. Okay.
And I saw a comment in the Q&A. Someone had asked about the American Heart Association and their recent policy statements there, and I think accurately pointed out that it mentioned medicines but not surgery. I will just say that we have at OEC engaged with the Heart Association. I will tell you that the fact that they're even talking about obesity treatment is a pretty remarkable thing. They would only work on prevention for the 2 decades I've been doing this. It wasn't until this year that they would work on treatment at all. So I think we have some opportunities to influence our friends at the Heart Association. And actually, having done a meeting with them recently, I saw the chair of the committee that's working on that speaking very highly of bariatric surgery, especially the cardiovascular outcomes after bariatric surgery. So I'm confident that you'll see some improvement in that area with some of their materials coming forward, and they are really working on what their policy positions are going to be going forward. And again, we can work with them on prevention. We worked a little bit with them on discrimination. They were supportive of that when we did some of our affordable care work. Like you couldn't exclude someone from a health plan because they had obesity. They supported that, but they've never touched treatment before. So I'm actually excited by that, even though there are some limitations on what they've published so far.
Yes, thank you for commenting on that. I appreciate it. So I do want to, I don't see any other questions or comments. I do want to just say thank you to everyone very, very much for attending this, for being panelists on this. We will have an evaluation we will send to you for further feedback and talk about next steps for another obesity summit Timing, I'm not sure when that will be, but we will work on that and keep you all in the loop. So thank you everyone very much. I hope you have a great rest of the day and a great weekend. And
thank you, Karen, for your leadership.
My pleasure. Oh, and I do want to just share one more thing that Shanu, oh my gosh, he is one of the best selfie picture takers, if you didn't notice in his presentation. All right, thank you. Good night.